more used in Delhi in comparison to Punjab, Haryana, and other states. But now,
not very popular in the South India, I think.
and it's not also in the FDA list, so the visa regulations and that's also people's mind that Covishield is listed. Good evening, Dr. Rajlakshmi.
Hi.
Hi, Rajlakshmi.
Yes, sir. Good evening.
Good evening.
My colleague in Coimbatore was talking about you, who was your classmate, Shiva Kumar. He's also an intensivist.
Yeah.
Like me, yeah.
M. Shiva.
Yeah.
Is it?
Yeah.
In fact, M. Shivakumar and myself worked together in Kobe Medical Center for about almost 15 years.
Okay. Okay, sir. Yes, yes. Now only recently he switched to different.
Yeah, switched to Royal Care.
Yeah. He is my batchmate.
Oh, very good. Very good.
Dr. Sahadullah, which vaccine are you administering there in KIMS?
Covishield.
Covishield. Okay.
And if the supply is not steadily coming through, we may have to go for the others, and we are not sure. Today, I think the central government and the state government, their representatives are meeting to make a call. There's no clarity in some of these things, and so.
True. I think Apollo is facing a shortage of Covaxin because they gave a first dose of Covaxin out here, and now I think Covaxin is not coming through. I don't know.
Covaxin, suddenly people are not taking even the telephone. We were calling, and now they are not taking even the telephone. I don't know why.
Is it?
So there is some problem there going on.
Okay.
Sir, kindly mute.
Yeah. Savio, I think we're past 10. Can we start off? I think all the speakers have joined.
Everyone is here, actually.
Yeah. Savio?
Except Dr. Sakaria. Sakaria can join Savio.
Yes, sir. Good afternoon. Sakriya sir is just joining.
All right. Okay. Okay.
We are waiting for. Thank you.
What about mucor, sir? Are you getting mucor in reasonable numbers or less? Because we are not getting in Delhi. We are, whatever cases are coming from UP and parts of Haryana and Rajasthan. So in Delhi per se, we are not seeing so much of mucor.
We have more of referred cases than in-house.
Okay.
Treated elsewhere and reaching here. One was treated in Gujarat, another in various parts of Tamil Nadu, and few from Kerala itself.
Our friend from PGI was suggesting that probably this cloth mask of which people are using for days and weeks without washing, and I say that's unhygienic. So that is also a probable contributing factor. He has made some observations on that. With this sweat and humid and dirty, this masks people are wearing on for days and weeks. Maybe it's a combination of so many factors, not just one.
Savio, can we go ahead?
I think we can start off, sir. We can start off. I think Rajamanik sir was not been waiting also. Okay.
Yeah.
So Sakriya was okay.
I think this is office anyway, Rajamanik. So.
Okay, we'll start off, sir. So good evening and warm welcome to the virtual conference on forecast and administration of COVID vaccine, hyper-automation, clinical testing, and diagnostics for hospital in Kerala to combat COVID-19. FICCI is really grateful to support given by Roche in organizing the program. As you are aware, this program is being organized for the various hospitals in Kerala. And FICCI being the apex body of Chambers of Commerce and Industry, and when the COVID started last year, we had organized an important meeting with the then Secretary Health, Government of India, and also with the important officials of Government of Kerala also, how to combat COVID and the issues related to the hospital sector. Thereafter, one more program was organized, and one full-day program was organized for the hospital sectors, including for medical devices and teams also. And we had also separate one-to-one discussion with the medical devices manufacturing companies in Kerala, also with the possible buyers and sellers in various parts of the country also, to promote the hospital industries and health-related activities in Kerala. Now, this is the series of the health activities. Of course, thereafter, we also did a program 2 weeks ago on the oxygen concentrators and the manufacturing facilities with indigenous oxygen manufacturers in India, and also with the various hospital as well as MSME units in Kerala, and also medium and large scale units to promote how to venture into oxygen manufacturing and concentrators. Now, this program is really useful for the, as well as this program is really useful for the hospital industry to get awareness about the vaccine sectors and also the clinical other topics which are being discussed in the sectors also, like hyperautomation, clinical testing, diagnostics in the hospital industry. We have a galaxy of eminent speakers for the session, and also to deliver the keynote address, we have Sri M.G. Rajamanikam IAS, Managing Director, KSIDC. Warm welcome to you, sir. And we also have other dignitaries, namely also of a co-partner to the program, Sri Dr. P.T. Sakrias, State President, Indian Medical Association, Kerala sector, and a galaxy of speakers, starting with the Professor Gautam Menon, Professor Physics Biology, Ashok University, Dr. Arvind R, Head of Department, Infectious Disease, Government Medical College, Trivandrum, Dr. Aniban Hom Chowdhury, Professor in Charge, Intensive Care, G.P. Pant Institute of Postgraduate Medical Integration and Research, New Delhi, Mr. U.K. Ananda Padmanabhan, Member Advisory Board, MGM Healthcare, Chennai, Dr. Rajalakshmi, Consultant, Infectious Disease, KIMS Health Management Limited. And also to take the session, we have with us our co-chair, Dr. M. Sahudullah, co-chair, FICCI Kerala State Council. I'm so Chairman, Managing Director, KIMS Health. And also our co-chair for the Healthcare Committee in Kerala, FICCI Kerala State Council, Director, Medivision and Scan Dynamics Research Center, Mr. Bibu Bipunuran. Warm welcome to all of you. Each of the speakers will be introduced prior to their presentation elaborately. And once again, warm welcome to the program. Over to Dr. M. I. Shahidullah, co-chair, for delivering the formal welcome address. Over to you, sir.
Hi, good afternoon to everyone. And, I'm very happy to welcome on behalf of the FICCI Kerala State Council. And all the friends, I think most of you are very well known to me, and very nice to meet the new friends. I'm rather getting addicted to the virtual meetings because in a way it is very good to meet friends, and you can attend more and more meetings sitting in your office. So this is a byproduct of COVID-19 pandemic. But we also miss meeting in person because of the same reason. I think I'm really happy to welcome each one of you. Just a few words, and then we can go into the program. We have a good program, as Savio mentioned. This a number of things, the vaccination program, and that is the talk all over the country today. COVID vaccination, we are trying to see the forecast and how we want to administer go forward on it. Automation is never, is all accepted that that's the way to go, even in healthcare, so that probably an inclusive, affordable care can be maybe innovated. Clinical testing and diagnostics is a real question, and we have a number of good speakers here. Just a few words about the vaccination, because our organization also, institution in Trivandrum and all over Kerala, we are actively involved in it. And still, if you look at it, the larger picture, only 3% of the country is vaccinated in the last 6 or 7 months we had. And so probably we have to catch up pretty fast in the coming, at least in the 6 months, because we have got a target perhaps like in December, if possible, to achieve the 80%, which may set off the herd immunity. So I hope that we can achieve quite a bit. We have the capability, but whether we have the organizational capacity is the question sometimes we wonder about. And so I think Dr. Rajalakshmi and some of the other speakers, talking about this, especially Professor Gautam Menon. And so we will be very happy to hear both of you. And then Aravind is here, and Aravind is the head of the Department of Infectious Diseases in Medical College Trivandrum, and he is very much with the government in making the policies for the thing. And so he will be talking about, Aravind is talking about, again, about vaccination and diagnostics. See, I think the pandemic has opened up our interest in healthcare, and now the second wave has opened up our eyes. And if you do a gap analysis, it has exposed quite a bit of deficiencies, and which not necessarily due to the financial situation. It can be also due to either governance issues and probably a disorganized approach. But having said that, if you compare with the many countries in the world, we have definitely in the forefront in fighting the disease. But certainly one thing is sure, that we have to go in a faster pace to achieve our targets. I do not want to go too much talking about the situation which you are going to talk about. But only one thing is that the vaccination is the core thing which we have to really achieve. And second is the reluctance for vaccination, which was initially there in most of the states, even including Kerala, is now getting better. And what else we can do really to stimulate this vaccination drive. So probably that's two questions we may have to face in the coming months. And of course, the vaccination, providing the vaccination, the vaccine is, of course, with the government of India, and they are doing a stupendous job organizing. And even today, I was told that there is a meeting between the states and the country and the government of India to really streamline where the private sector is coming, where the government sector is coming, and all that. Okay, with these words, I would really love to welcome Mr. Rajamanikam. And Rajamanikam is, a good friend, and he is the managing director of KSIDC, and he's got his MTech from Madurai University, and he was in various positions in Kerala, a very popular, bureaucratic officer, and he was in charge. Actually, I had to contact him on several occasions because he was in charge of the oxygen war room during this crisis, and you are still in charge, I think, along with the KCDC duties. And so he has occupied very decorated positions in the state before this. So that is, so welcome, Mr. Rajamanikam, to this gathering. Thank you. I am very glad to see Mr. Anantapatnabhan, who is an old friend, and medical. Now he's advisory board in MGM. I know him when he was in Korea Hospital, and now he's in MGM. And in MGM also we have some tie-up for cardiac transplant. So it's nice to see you with entrepreneurship. And then Dr. Zakaria is a good friend. I don't know whether he has joined. And he is an Indian Medical Association president. Zakaria, has he joined? No, yeah, okay, yeah. Welcome to this meeting. And Dr. Aravind, I already introduced, and Aravind is head of the ID infectious diseases department, and also working closely with the government on policies of combating COVID. Dr. Rajalakshmi, I'm very happy to have her. She is our own institution, head of the ID department, and tremendously contributed to the various, crisis management and healthcare workers falling sick every day, and also in the vaccination drive. So she's in the forefront of every one of these things. And then whom am I missing? Professor Gautam Menon, Professor of Physics and Biology from Ashoka University. So very nice to welcome you. You are talking about the forecasting and of the vaccine administration. And Anirban Home Chaudhary, professor and in charge of GB Pant Institute of Postgraduate Medical Education and Research, New Delhi. Welcome to this program. And I think finally, but not the least, committee co-chair of FICCI Kerala State is Bibu Punuran, good friend, and he's also director of Medical Vision Scan and Diagnostic Research Center, and he will be moderating the program. And I also welcome all the attendees and the invitees, government representatives and representatives from the industry, and all of you. Once again, my hearty welcome. And FICCI has always remained very active in this epidemic to work with the government of India as well as the state government to not only contributing in many ways, but also in policy making. And with these words, I welcome once again every one of you. And can I go over to Bibu or over to Savio?
Thank you, sir. Thank you.
Yeah. Thank you.
Before welcoming Sri Rajamanikam IAS, Chairman and Managing Director KSIDC. In fact, Dr. Shabdullah has already introduced Rajamanikam, sir. He is well known to everybody, so I'm not going to his profiles. But just one word from the FICCI side, sir. We have already given a representation to the Government of India regarding the permitting to the organization to work those companies who have already vaccinated their employees. And also, we also requested our companies to get vaccinated, all their employees and families, and all their neighborhood locality also. So the process is being going on throughout the country, and Kerala also we have started the process. So over to Sri Rajamanikam sir IAS for the keynote address.
Thank you, Mr. Samuel. And in fact, thank you for inviting me to this August forum with eminent, speakers around discussing about this, forecast and administration of COVID vaccine and technologies. As far as, me as outlier here is concerned, you're all, technical and experienced people in terms of healthcare, this one. So what I can add here in the keynote is my bureaucratic experience of the COVID, how the technology can help to, solve this issue. See, as far as, we are concerned, pandemic, we have been hearing in the history, whether it is a Black Death, Spanish flu, or Bombay plague, or whatever. So far, we have been heard about this, pandemic throughout, because that the history, this many people's, million people's died, and so on and so forth. But as far as this COVID, which is different from the other pandemic, is at the same time, like as a massive populations throughout the world, which is affecting. At the same time, the vaccination, which is also, going throughout the world. So I would rather see this COVID-19 pandemic as not only presented challenges, but also several, opportunities, though with, lot of, cost in terms of death and other things. Basically, like, as far as, present the issue is concerned, the main focus as far as, India is concerned, at least developing world is concerned, is the vaccinating the population against this COVID-19. Because it's not only the vaccination. The problem is that the most problematic thing is that the immense distribution and logistical challenges everyone actually, ever faced, as far as any pandemic is concerned. That is the biggest problem actually we have. See, across the globe, research is, actually undergoing on how technology like artificial intelligence or, blockchain technology or machine learning, any technology, that is how the hyper automation comes in. So how that can be helped, with this, task especially. But as far as we are concerned, our developing countries are concerned, is that forecasting of, this demand is a major and key challenge actually. So as far as, rollout of this vaccine distribution or administering is concerned, is like I discussed, in fact, last month I was being appointed as a special officer COVID for a particular district, say called Malappuram district. My main agenda or task is to, because TPR was, close to 41% in the district. My main task, given by the government of Kerala is to, do whatever, administrative activities so as to, we need to, control the spread as well as reduce the TPR. And naturally, we cannot reduce the TPR by bringing down, number or kind of thing. So it's, a lot of, complications involved. But still, so bureaucratically, whatever the way possible, of course, with the help of, people like you in the healthcare industries and healthcare professionals, whatever the possibility that, I have tried. But one practical thing which I noticed, which would be very apt for this, forum to discuss also, because you are discussing about hyper automations. There are, maybe it falls to diagnostics also, especially when it comes to the testing. Malappuram is one of the highest populated, district of Kerala. Close to 48, lakhs of people with very high density and all those things are there. And as far as testing is concerned, because at one point of time, 40% means like, close to, 16, 18 lakhs people are affected at the same time in the district. And how the infrastructure is going to manage, especially testing, vaccination, all those things are biggest headache. Along with that, we have a, biggest task of reducing a death rate, which is a very, very important as far as is concerned. And everyone knows Kerala is one of the least, death rate, which is close to 0.25 only actually. So that was the biggest task. But what the difficulty I faced as far as the testing is concerned. So anyone who is having a kind of a symptoms, because our task is that supply whether antigen or, RT-PCR kits to different mobile lab or whatever, hospitals or something like that. There are a lot of, private, especially small outreach, centers also, we were, given the task of testing. Everyone is going and testing, and we were not able to collect the data properly. Say, for example, at one point of time, say in one small center, somebody is going, say, 200 numbers are going. Ultimately, this small center, what they are doing is that they are only entering the data of the positive persons, no negative persons. In the sense, like, so that, positives are reported, no negatives are reported. That automatically suits up the TPR. So basically, why I said this point, this is one small incident about the one outreach center. There are thousands of outreach centers across, Kerala, across the districts. So data compilation and diagnostic was very, very challenging one, where this hyper automation definitely will come into play, because hyper automation, as everyone discussing, is automating the automated process. Actually, it's a super automation kind of thing. So use all kind of a technology, whether it's artificial intelligence or machine learning or robotic processing or any kind of a technology, so that minimizing the human intervention and maximizing the machine kind of algorithms and diagnostics. So in future, because it is not going to end here, we may also face a kind of one more wave or something like that. Everyone which we are talking about. So how such kind of hyper automations can create a protocol, which definitely this August forum can discuss, and definitely that will be helpful to the not only government as a healthcare sector, as a total, number one. Number 2 point is like what I want to insist upon is that, like, I mean, as far as Kerala is concerned, because Kerala has taken a lead, especially our honorable CM, once the second wave is, has come, he was so interested in, whatever the possible way that, because as everyone knows, when oxygen demand is shot up like anything, Kerala is the, I would not say only state, at least we managed well to meet the demand of, Kerala healthcare industry, both in private as well as the public. Because, thankfully we have had, 170 metric tons of, inox is there. Apart from that, we have got some, this one from Government of India also. Our peak demand was close to 400 tons per day, and we have not faced a single day. We have not, faced any kind of a supply gap actually. So that much, all through all your help and system, that definitely, we are proud to say that yes, we achieved that. But the thing is that, post this, second wave that Honorable CM has said, so in future, we should not think private, government, this and that. Citizen is citizen. So we need to think in a larger perspective, so that in post-pandemic, this perspective, Government of Kerala has to come forefront and offer a kind of, any kind of, offer to the industries who want to invest, especially healthcare industry. They have to come up with the technology they can invest, and we are open to any kind of ideas kind of thing. So especially vaccine, and everyone knows that government has taken a cautious decision that Kerala, it is not we are developing vaccine. We need to develop a vaccine line immediately, because the KSIDC have, life science park, which is, kind of visionary park, wherein that any kind of life, already Institute of Advanced Virology is there, and Sri Chitra and KSIDC's joint venturely, we are doing medical devices park. Dr. Sagadullah already KIMS is also coming in for medical devices actually. So like, we have life sciences park with all kind of facilities, techno park opposite to provide a technology platform, and everything is there. So we are, planning to have a kind of a vaccine line, so that in future, because we don't know whether, COVID, second wave come, third wave come, or any other virus in future come, we don't know. We should be capable enough to, it is not that, we create a vaccine kind of thing. We should be capable enough to at least address the issue of the citizen in Kerala. So even, it's not a, profitable things we are looking into it. Any kind of technological partner or investment partner in terms of anything related to the COVID, as immediately, like it can be diagnostic or anything, is most welcome. Already KSIDC has invited the expression of interest in this regard. So, these are all the things from the government side which I can, offer at this point of time. And really thankful to the FICCI, for inviting such a wonderful discussion with the great, eminent speakers are all here to forecast and administration of COVID vaccines, especially clinical testing and diagnostic, which I have already mentioned about the problem we faced, especially the diagnostics. A challenge can be undertaken by the private industries also. What we need diagnostic is that, because I can see Mr. Bibu, we need to adopt a hub and spoke model in future at least. A major diagnostic center, because nowadays diagnostic earlier in my childhood is like, a doctor, advised to go and test somewhere else, and we go to some laboratory. Now that becomes a part and parcel of the hospital and part and parcel of a kind of a big venture. So we need to try to create a hub and spoke model along with the technological automations, so that whatever the data which I say, it should not be missed. And second thing is that we already have enough of data, because especially in Kerala, close to 1 crore dose of vaccination we have been given. Every day, close to 1 lakh, test we are, undertaking. These are all the data which is very, very important. Somebody who understands about data, it is like a very sensitive information also, but at the same time, we have close to 3 crore, population data with, health diagnostic is there. 1 crore data with, doses is there. So how it can be further utilized to betterment of the society is the health sector has to analyze at this point of time. That is what I would, insist upon here. And thank you, FICCI, for inviting me to this, August gathering. Thank you so much, and thanks, Nandal.
Thank you, Rajamani Kishore, for delivering the keynote address and also raising the very valued points. Of course, that will be discussed in detail by the panel of speakers. And of course, for the awareness of our speakers, there is also part of the committee to constitute that virology research centers that's coming up at the Life Science Park also then for the vaccine research centers also. So there is part of many committees also. Definitely, FICCI will be in touch with you, sir, for further collaboration on these sectors also. And also regarding other issues, definitely we'll come back to you after the meeting with the third industry issue. Thank you, sir. Thank you so much for joining. And we also have a very important speaker for the session, Dr. P. Zacharias, State President, Indian Medical Association, Kerala Branch, I know that you know that Indian Medical Association has a very important role to play. And over to Dr. P.T. Zacharias for the special address. Thereafter, we will have the discussion with the eminent speakers, and Bibu Punaran will take over the proceeding from there on.
Thank you, Mr. Savio Matthew and Dr. M.I. Sadagullah of KIMS for good introduction of myself. Now it is Rajamanikam IAS has detailed everything. It is not the fault of the administrator. We have been invited by the Chief Secretary many times, and request to us to increase the pace of vaccination. And he and the Health Secretary were together to stimulate us. But after that start, it is not progressing, and the vaccination is not moving very fast as we expected. So vaccination has proved to be one of the most important tools to prevent this pandemic. And we have covered not satisfactorily the population, as Dr. Sagadullah has told. We are still having some trouble somewhere. India has an experience of vaccinating, universal vaccinating all the children below from the infancy, and we were successful in that, in preventing many monster diseases. Now this is affecting it as a new epidemic, and all ages has to be protected from this, because if a successful vaccination has taken place, and if a successful speed has attained, this will save many of our Indians from untimely death. Already we have lost about 700 doctors in the second wave and 833 doctors in the first wave. So they have sacrificed for the service of the COVID patients. And we will not be fatigued and withdrawing from the field. We will be very actively focusing in prevention of this pandemic, which has come uninvitedly to our country also. And more than 200 countries in the world it is affecting. Even small island countries are not spared from this virus spread. Our Chief Minister was telling that the Delta variant of the virus can spread very fast, is now in India. And this genetic change has made the virus very fast to attack people, and we have to vaccinate also very fast. At least one dose will help the population. That is our findings from the field. But to vaccinate, there are incidences when people have died out, even though they are vaccinated twice, as per directive of the government. But we have to. We have other data also. Vaccination has saved many lives of very elderly people. And I am very kind for the FICCI for organizing such a meeting with so many dignitaries. Indian Medical Association has started, because of the assurance of the Chief Secretary and Health Secretary, we have started 11 centers of vaccination in Calicut district, and some massive camps in Malappuram district like Tirurangadi. And we have conducted many CME program using our Dr. Aravind, who is now available in this forum also. And he is a very knowledgeable person, I know, because when I was in the Trivandrum Medical College, it was Dr. Srikanth conducting this infectious disease department. And I was interested because I was the first full-time director of the Virology Institute of Alapi, Kerala State Institute of Virology in Alapi. So I was interested in all virus diseases prevention and fight. And even now, IMA is not behind anybody, even though the healthcare workers throughout the state are a bit fatigued because of the continuous duty and this COVID duty and wearing PP kits, and they are on duty without rest for more than 450 days, 450 days now almost. And we are not behind anybody to help this Bibi Punuran He's a very academic person, and he's also very known to me. And other Dr. Rajalakshmi is from KIMS, it seems, and Mr. Savia Matthew has introduced the thing. Rajamanikam sir is a very, very famous IAS administrator. He will be beginning none in his administrative capacity. Thank you very much. Indian Medical Association will be helping, and Dr. Sahadullah can lead the show. We will always be helpful to and mobilize our rank and file in providing vaccination at the earliest. Thank you very much for inviting me for this.
Thank you, Dr. P.T. Sakriya, State President, Indian Medical Association, for delivering the special address and also raising the concerns of the industry, especially with the health professionals and sectors, and also assuring the support and cooperation in this regard. That completes the inaugural formalities. And I would request Mr. B. Punaran, Co-Chair Healthcare Committee, FICCI Health, FICCI Kerala State Council, Director Medivision Scan and Diagnostics Research Center Private Limited, to take over the session as the moderator. Over to Bibu.
Thank you, Savio. Good afternoon, everyone. Dr. M.I. Sahadullah, Co-Chair FICCI Kerala State. Dr. P.T. Sakriyas, I'm a Kerala State President. Mr. Savio Matthew, Head FICCI Kerala. Officers of Roche, who are our principal sponsors for the evening. And all our eminent speakers for today. My duty today evening is to introduce each one of you and also hear from you, because you all four of you are the experts on the subject, on this particular subject that we are talking about. And as we all know, this COVID pandemic has hit us all hard, very hard. And to continue what Mr. Rajamanikam and Dr. P.T. Sakriya said, I think there are this COVID has got is a three-pronged problem, or a three-pronged challenge, if I would put it that way. One, of course, is the testing side. And the testing side, if you put it, it is not just the RT-PCR or the antigen testing alone. There are the higher end tests like the IL-6, the PCT, and all the other tests involved. That is one thing. The other challenge would always be the reporting, which is equally important. As our keynote speaker just said, most of the tests that are done, probably the negatives are not reported on time. That is where hyper-automation also comes in. And then, of course, the final verdict or the final way would be the vaccination. All these are challenges in a country, especially like ours, which is so populous. We can always blame everyone, keep blaming each other politically, this way, that way. But end of the day, we have to see that we have all got to join our hands together and then keep us going forward. Let us hope that there will be no more fatalities because of this pandemic. And let us hope that our country will bounce back to what it was, a very much growing economy in the future too. Let us be recognized as one among the best countries in the world for tackling this pandemic, at least in the future. Because I'm sure that there probably might be another wave that might come in as per predictions. We're coming over to our business session for the day. The first session, we would be having three speakers, Professor Gautam Menon, Dr. Rajalakshmi, and Dr. Aravind R. And I would request all of you to keep your sessions to 12 to 15 minutes, after which finally, after every speaker has spoken, then Dr. Anirudh Chowdhury will come and Dr. UK Another Patnabhan would come. So before each speaker speaks, I would be introducing each of you, and then probably we'll have a Q&A session after the whole thing. So if I may go into my duty, I will first of all, in the sequence of the events, Professor Gautam Menon, I will introduce him and ask him, and I'll ask you, sir, to kindly speak to us. So just for the benefit of all those present here, may I just introduce Professor Gautam Menon first. Professor Gautam Menon is Professor of Physics and Biology at the Ashoka University. And prior to joining Ashoka, he was a professor with the Theoretical Physics and Computational Biology groups at the Institute of Mathematical Sciences, Chennai. He is currently an adjunct professor in the Department of Biological Sciences at the Tata Institute of Fundamental Research, Mumbai. He's completed a BSc in Honours in Physics from the St. Stephen's College, Delhi, MSc from IIT Kanpur, PhD from the Indian Institute of Science, Bangalore, and he was awarded a DST Fast Track Fellowship for Young Scientists in 2002 at the Swarna Jayanti Fellowship of the DST in 2005. It's over to you, Professor Gautam Menon.
Thank you, Mr. Ponuran. Let me just share my screen. So I hope you can now see my full screen. Thank you for this invitation. Thank you to Vicky for asking me to speak here. I just want to quickly survey what we know about vaccines. And at the end, I will talk about what may be outstanding problems that we have to deal with. And many of the speakers who went before me alluded to some of them. Let me give you my own perspective. First of all, what sorts of vaccines are there at the moment? There are whole vaccines that are inactivated currently. Covaxin is a whole virus, inactivated whole virus vaccine. There are non-replicating viral vector vaccines. Covishield and Sputnik, which has just come into the market, is an example of that. And the Zycov-D is a DNA-based component vaccine. It just has some part of the genetic material of the pathogen itself. So this is a whole range of different platforms that exist: the RNA-based viruses, the virus-like particles, the protein subunit. And of course, there is development along all of these currently in India. There are 4 vaccines approved for use in India currently. You know, the Serum Institute of India's Covishield, which is approved in 40 countries, 2 trials in 1 country. There's the Gamaleya, the Sputnik V, which has just been, Sputnik V, which has just come in. There's the Oxford AstraZeneca virus, approved in 102 countries. And there is, of course, Covaxin from Bharat Biotech. So these are the 4, the sort of spectrum of current vaccines that are available in the country. And of course, there are a large number of them that are currently under clinical trials. So there are 13 of them which are undergoing some form of clinical trials, including from Biological E, for example, another one from Bharat Biotech, Gamaleya, et cetera, et cetera. So there is a large, currently multiple platforms for viral research in the country and for the development of vaccines. The vaccination program in India went in 3 phases. The first phase started on the 16th of January, which was limited to healthcare and frontline workers, around 30 million of them. On March 1st, this was reconfigured into 2 parts. The first part was to allow people over the age of 60 and those above age 45 with somewhat stringent conditions on their comorbidities. This was then extended on April 1st, 2021, where the eligibility was extended to everyone over 45, irrespective of any prior comorbidity. On the 1st of May, this was extended to anyone over 18, so including the 18 to 45 age group as well. And effective June 21st, a few days from now, there's a new vaccination policy which will be implemented. So here is the essentials of the new vaccination policy. I'm going over some of this, although I know that many of you are already very knowledgeable about this. The idea is that every citizen above the age of 18 will be vaccinated free at central and state government centers. Earlier, it was only free vaccines were only available at centers run by state governments, but now what will continue to be a priority is the 3 groups: healthcare workers, frontline workers, and those above age 45. And at private centers, citizens will have to pay for vaccination. So that's a division between the public and the private aspects of the vaccinations. The center will procure 75% of manufactured doses and distribute this to the states to be administered for free. And private hospitals will have exclusive access to the remaining 25%. The allocation will be determined through a complicated formula based on population, burden, also wastage of vaccines. So good vaccine coverage will draw a higher number of doses and higher wastage will begin less. The exact formula is not known currently, but this is what will drive the decisions regarding how the center will disperse vaccines to the states. And state governments will also aggregate demand of private hospitals, keeping in mind questions of equity and balance across regions. Vaccine prices will now be capped. So in the private sector, the Covishield will be capped at 780, Covaxin at 1410, and Sputnik at 1145. And there will be a condition for those who were unable to access the app, the CoWIN app. There will be an online registration facility that will be provided at government and private vaccination centers, but the procedures are yet to be finalized regarding this. So this is the final cost, including the service charge to private hospitals. Priority groups continue to remain, as they should remain, healthcare and frontline workers as a priority. As we have been arguing many times, it is important to do the age prioritization in order, and certainly above 45. Currently, everything that we understand about COVID-19 mortality does suggest that elderly people are far more at risk than younger people. There is no change of that really between the first wave and the second wave. The second wave has just seen a larger number of cases overall. Supply agreements have to be worked out with a bunch of other providers, Johnson & Johnson, Moderna, Pfizer, et cetera. But potentially these are vaccines that will enter the market within the next few months, hopefully, once they sort their problems out. Here are the numbers. It's about 253 million people. So 25 crores, 36,99,043 as of today. People who've been vaccinated. That's about 21.8% of adults in India. 42% of those aged above 45 and 45% of those aged above 60. These are not very good numbers. We would like to have seen the population above 45 and above 60 to go up, hopefully to about 70 to 80%, because as I said, they are the population that is most at risk. But this is a group that has been administered at least one dose of COVID-19. And although this is 15% of the country's population, so 15% of the overall country's population, 21.8% of adults in India, that is above the age of 18, only 3.5% are fully vaccinated. And this is an extrapolation based on the population in 2021, because the last census that we had was in 2011. So we don't know the exact population numbers as yet. Very inhomogeneous across the country. Kerala is doing relatively well at 8.4, Maharashtra at 5.7, Telangana at 4.8. And this is the percentage of people vaccinated with both doses. So the overall India number is about 5%. And you can see that Kerala sits a little bit above that. This is as up to date as it can get. Here's a quick calculation. So estimated population of India is around 1392 million, 1.4 billion, roughly speaking. Let's say 70% of these are eligible for the vaccine. That's the 18 plus population. That's about 974 million, roughly about 1 billion. You need 2 billion doses roughly to vaccinate everyone with a double dose vaccine that are currently available in India. You've already vaccinated 250 million, given the numbers that I told you already, with at least one dose. The current vaccination rate is about 3 million per day. It's about today actually has been fairly good. It's close to 4 million as of date. So if I take the 750 million divided by 3 million per day, that works to about 250 days to give people at least this round of doses. That's 8 months if you do it non-stop. Of course, this will obviously overlap to next year, but that's assuming that the pace of vaccination stays constant, which will not stay constant. It will obviously increase. So currently, the constraints are those of supply. They're not really of uptake. As was pointed out, hesitancy has come down, but supply has not matched the increased demand for vaccines of people who want to get vaccinated. Even within these numbers, one has to prioritize frontline workers and 45 plus, especially with comorbidities. This is how the distribution is. Really in India, overwhelmingly it's Covishield by 90% to 10%. Covaxin is a smaller amount. Sputnik is a very, very tiny amount currently. There are more males being vaccinated than females. There has to be some, that's again a question of equity that we have to sort out here. This is the distribution across age groups. So over 60, 63 million, over 45 to 60, 81 million, 18 to 44, 57 million. The 18 to 44 is still somewhat largely, I think, healthcare workers, frontline workers, etc., because they were part of the original 30 million that were to be vaccinated in the first round, starting January 16th. Here are projections from the government as to availability of vaccines. It's projected that the SIA will be able to contribute 950 million doses by the end of the year, between August and December. Bharat Biotech, 650 million doses, biologically 300 million doses, Dr. Reddy's 156, Dr. Reddy's with Sputnik V, Zydus Cadila, the new vaccine that is still in trials, 50 million doses. This all seems a little bit ambitious. Whether these numbers will work out is not completely clear. But if they all worked out, if you add these numbers up, that would give you the sort of numbers that you would need to vaccinate everybody in India with 2 doses by about December. So this is a hopeful sort of possibility. If it can be achieved, that's very good. It's somewhat unclear what the situation will really be about 2 or 3 months from now. As Kerala has done, it has prioritized certain groups of frontline workers, and this is a very sensible prioritization. People with disabilities, Indian Railways, KSRTC, vendors of various types, etc. And many states are doing the same thing with somewhat different sort of numbering. But essentially, this is people in frontline occupations who will be required, who are at most at risk of contacting COVID-19. Couple of points about what we know currently. We know that the new variants are more infectious. They show some level of immune escape. They also show some level of vaccine breakthroughs, people who develop disease after 2 doses of vaccines. The more you have in terms of numbers of people who are infected, there is more scope for new variants. So in order to reduce the risk of new variants, the only thing that you can do is to drive infections down. So combinations of whatever you can do, lockdowns, isolations, vaccinations, this has to be done if you want to prevent the risk of a new variant emerging. There are some, exactly what is the regime of the dosing. For Covishield, it was initially tested using a 4-week prime boost, but real-world data showed that it did a little better when you delayed the second dose by 8 to 12 weeks. And now there's an active discussion about whether, when the new variant is taking off, whether you should reduce that time. And currently, we are administering in India 2 doses of Covishield at intervals of 12 to 16 weeks. There was a robust discussion about that. The earlier gap was 6 to 8 weeks, and now it may come down a little bit towards back to 6 to 8 weeks, given the discussions that are going on currently. Both the Indian vaccines, both Covaxin and Covishield, have reasonable efficacy. What the official phase 3 trial results for Covishield show you 70% vaccine efficacy. The unpublished Covaxin phase 3 trial results show you 78% from the numbers. But it's important to remember that efficacy is under very specific trial conditions. That is not effectiveness as measured in real life situations. The third wave in India could potentially be sparked off by a new variant, and there is a whole number of dangerous potential new variants. Right now, the Delta variant, the B.1.617.2 variant, which really was observed first in India, is probably the worst of them in terms of being the most transmissible of the lot. Here is a nice example of how fast it has taken over. So this is the spread taken from GIS state data for 617. 617 is that purple color that you see on the right. And all of the other variants are shown in the other types of different colors. As you can see, starting from June, July, August, September of last year, you can see how the 617 variant has actually expanded hugely at the expense of the other variants. It's a very, very classic picture of how a more transmissible variant can take over a less transmissible variant just over here. So 617.2 is associated with more hospitalizations, maybe associated with more morbidity. We don't in general, but mortality we're not so clear yet. But this is a nice example of what happens when you have a more infectious variant taking over. A lot of studies are coming out right now on breakthrough infections. And overall, the message is a positive one, that even if you've been infected, if you have 1 or 2 doses of the vaccines, whichever vaccine they are, there is still a substantial level of protection against severe disease, against death, against ICU. So, for example, recent Kerala data of a large number of breakthrough infections among vaccinated healthcare workers, none of them required oxygen or ICU units. So this is a very important point to mention, that the vaccines are very effective. They're effective also against the new Delta variant, even though that is a variant that hits unvaccinated people much harder. And the number that we're seeing now from Public Health England are actually very good numbers. So Oxford AstraZeneca is 92% effective against hospitalization after 2 doses, which is a very, very good state of affairs to be in. So let me just finish by making some of these points. One is about the potential third wave. As a person who works in disease modeling and who's been very interested in COVID-19 over the past year or so, models seem to suggest that it's not essential that you will have a third wave. We talk about the third wave, and it is good to prepare for a third wave, but there are reasons why a third wave may not take off with the sort of intensity that we saw in the second wave. One is that a large number of Indians have already been infected, roughly 30% of the population in the first wave, roughly double that in another 30% in the second wave, maybe 60 to 70% have had some exposure to the disease so far. In that context, given that a prior infection gives you some level of protection, given that a prior infection plus 1 vaccine dose gives you a whole lot of protection, it's possible that what you will see will not be as severe as what you saw in the second wave. It's important, as was mentioned earlier by the speakers, to remove hesitancy. Hesitancy is an issue across much of the country, and it is important as healthcare providers and people who work in this area to concentrate on removing the hesitancy so that more people can be vaccinated as possible. Increasing vaccine uptake among high-risk groups, that is where the mortality lies. So again, 45 plus, comorbidities, diabetes, 60 plus, etc., is where one should put a special effort. The point to communicate is that any vaccine works well at preventing severe disease and death. There are always anecdotal stories. My uncle, my aunt did this, they fell ill, they had 1 dose, 2 doses. But these are anecdotes. If you look at population-wide figures, it's very clear that the vaccines, whichever vaccine they are, continues to work well and they prevent severe disease. In order, as I emphasized earlier, to prevent new variants, you should suppress case numbers, bring them down whatever way you can across the world. So it's not just an Indian problem, but a worldwide problem that we should concentrate on this. The last point is equity. As I pointed out, male-female numbers are still skewed in favor of the male. There's no reason why in a 50% population that should be the case. We should concentrate on reaching vaccines to populations that are underserved, tribal populations that is hard to reach, where even the disease may not have reached yet, so that they can be protected in time. With that, let me thank you very much for your invitation. I hope this has been helpful. Thank you.
Yeah, thank you very much, Dr. Gautam, Professor Gautam Menon, for having addressed us. And we definitely have a lot of encouraging uh, news from you. Or rather, it is your talk was really on a positive side, because the first and foremost thing is that I feel, or rather, from what you said, you have reassured us that most probably there will not be a third wave, which is actually good news for the entire country. And you have also taken us through the new vaccination policy, the pricing, the statistics of the vaccines, the supply. And the biggest thing that you have said is that perhaps in a country as large as ours, we would probably be able to finish, looking at the current supply, we would be probably able to finish vaccination, or at least a majority of the vaccination drive would be completed in the next 8 months or so, which, if it really works out, would be the biggest thing in history for any country of our stature or our size. Thank you very much once again. We have had a few questions in the chat box, but we would request you to kindly wait, because for taking the questions, because we would like all the speakers to finish, and then we'll go into the question and answer session.
Before, can I just intervene? Okay, for the convenience, for the awareness of the speakers, there's a large number of participants have joined for the program, but since the program is being done at the FICCI BIKE platform, for the convenience sake, we are having only the speakers being displayed in the participant list. Rest of the people are watching in the FICCI BIKE platform as well as the YouTube link. So large number of people are watching this program, just for your information, sir. Okay.
Yeah, that is where from the questions are being posted. Yeah. So that's for the information of all the speakers out here. So thank you once again, Professor Gautam Menon. Now I would request Dr. Raja Lakshmi to speak, but before she speaks, I would like to introduce her also. Dr. Raja Lakshmi is a DNB in Medicine and FRCP, Fellowship in ID, CIC Senior Consultant in Infectious Diseases, and HIC KIMS Health Trivandrum currently. She did her MBBS from the Coimbatore Medical College, her DNB from the Trivandrum Medical College, Infectious Disease Fellowship from Apollo Hospitals, Chennai, Observer in Transplant Infectious Diseases in Wayne State University, Carmenos Cancer Center, Detroit. And she's a board certified in infection prevention and hospital epidemiology. And she has 20 journal publications and 24 paper presentations to her credit. So that's Dr. A. Rajalakshmi for you. Over to you, Doctor.
Thank you all. Good evening to you. Is my slides visible and am I audible?
Yes, you're audible.
Thank you. Thank you so much. Thanks, Vicky, for the invitation. It's my privilege to be here and then to talk on this very important topic. And there may be more questions and solutions, but we will try to arrive at some solutions at the end of the talk. So the topic is forecasting vaccination and advanced planning of COVID-19 management in Kerala. And there will be some overlap with my previous speaker, Professor Gautam Menon. I understand that he has touched many of what I'm going to talk about. And then my next speaker will be touching upon the genomic aspects, the variants, and what Kerala has done so far and what we hold for the future. So we all know, as this is the statistics, India has touched crossed 29 million cases of COVID, and it is only second to US. And we know that our daily cases after the second wave is declining, the deaths are declining, and the vaccination rates are increasing. And that we have crossed 20 million people who are vaccinated so far, at least with one dose. About coming to Kerala, we have again 2 million cases, 10,000 deaths so far. So our second wave was really brutal on us, we all know. And we all know that social distancing and mask is not the thing in India because of our population, as well as the crowding, as well as our nature. We love gatherings. Social distancing and mask alone cannot save us. That is, we have understood both the first and the second wave. And so we have only one solution of developing herd immunity, not by infections, but by vaccine. So Jan 16th, yes, we rolled out the vaccine large scale. Healthcare worker, frontline worker, and more than 60 years of age were the target population. And at that time, we were lucky. Our supply was more than demand, as there were vaccine hesitancy. So we had plenty of vaccines, and we were able to even export 65 million doses of vaccine at that point. Late in March, April, when the doors were open for those above 45 years, the demand became more than supply. And by that time, we had approximately vaccinated 143 million, but only 1.5% of the population were covered at that time. And above 60 years of age, only 50% were vaccinated. And by that time, we had another 200 million joining the queue in March, April. And April was the worst month for us, as well as May, when we had the second wave, the tsunami of COVID, as well as we opened the doors for those aged more than 18 years. And you can imagine, with this, we have 900 million are now eligible into two, that each one requires 2 doses. So we needed around 1,800 million doses. And at that point, our manufacturing capacity is only 110 million doses per month. And with approximate estimate was it will take 18 months for the required doses to be manufactured and given to the population. So these statistics were very well described by the previous speaker, but I'll touch upon that before I go. So this is the number. Yes, 250 million we have vaccinated as on 13/6. Kerala has vaccinated 11 million. So we have a long way to go. And if you compare the percentage of population vaccinated, Canada and Israel have already attained herd immunity because they have reached around 80% mark in the population. And we are now somewhere around 15% of our population has been vaccinated. Though the sheer number is huge and we have vaccinated in rapid scale in a shorter duration, still, because of the sheer population that we have, the percentage of vaccinated is only around 15%. Coming to Kerala, yes, this is as on data as on 11/6. We know that Ernakulam and Trivandrum received the maximum vaccines, the number of shots, and the total number, as I said, has crossed 11 million. Above 45 years of age, as on 12/6, 60% of the population have at least received 1 dose. That's good news. And 1/5 of the population has received at least 2 doses, have received 2 doses. And between 80 and 44 years, because we opened the door only in late May, only 6.7% have been covered so far. We know that it is, we will do it in the coming months. So it's a long way to go, vaccinations in Kerala. But looking at the functional center in the state, it is a little depressing. As you know, we have only 781 total functional center. And I was even surprised that Trivandrum was having only very minimal centers at that point of time, as in 11/6. And there was some good number of vaccination centers going on in Malappuram, Palakkad, Pathanamthitta districts, as you can see. But in the coming days, as the vaccine supply improves, we believe that these numbers will increase. We need more vaccination centers to reach the target. So this was what I saw in the COVID vaccination drive should be a surgical strike, is from the message from Bombay HC to the center. And because the clock is ticking in the COVID vaccination drive, we are lagging behind. And they were even comparing it as corporate bombing. But there are several bottlenecks, as you can see the list here, and we'll go one by one as how to overcome each of this. Vaccine supply, heterogeneity, and investment in production is the main thing that we have to look at now at the current point. We know that Serum Institute of India and Bharat Biotech has beefed up the production from the earlier 110 million doses per month to 158 million a month in 4 months. They have increased their capacity. That's good. State-owned facility, which has actually collaborated with these 2 institutes, especially the Bharat Biotech, the Indian Immunologicals Limited, Bharat Immunologicals Limited, and Hafkin Institute. They helped with 50 million doses of Covaxin a month from August. That is the projected numbers. Reddy's Lab, as we know, Russia brings the Russia Sputnik vaccine. That is 250 million doses at one go. That's expected anytime. And this is a little reassuring information, that is Novavax. It's a newly approved vaccine in US, which has a very good efficacy of 90.4%, which is actually they are planning to collaborate with Serum Institute of India to make the vaccine in India. And this is again a technology transfer, a nanoparticle based spike protein based vaccine. And probably the US has enough stock of Moderna and Pfizer, and they may even, this Novavax may even venture into India to collaborate with Serum. This is a good news. So with everyone eligible might be able to get their first dose with all these possible combinations by mid-October and the second dose by January end if there are no hiccups in production and distribution and the vaccine take. So why partner with private hospitals? We need to vaccinate as many as possible in the shortest time. That is our target, because we will have many more waves to come and we have to face them with a little fatality. So what are the bottlenecks the private hospital face? Advance payments that the vaccine manufacturer expect, which many of the small scale hospitals are finding difficult, especially in the COVID season, because of their losses that they have incurred, and the low margin of benefit because of the capping of prices. What everybody points as a reason is they spend a good amount in maintaining cold chain, manpower, infrastructure, and these are the issues they face. So they are even scared to invest in vaccines. Adequate supplies to be provided, and not in piecemeal, but provided at least a week's supply. When you get a vaccine supply to go uninterrupted with appointments, you need a good supply. If it is interrupted, and it comes suddenly to stop, then it is very difficult to start again. That's what the challenge, main challenge that we face. So preparing for this is a good news that I found in the newspaper today. Preparing for the third wave, target set to vaccinate 2 lakh people per day. So with this message, what we expect is a 6 million doses offered per month, but supply alone is not enough. We need willing public, manpower, and other resources to make it practical. So worksite vaccination is another important aspect. We know that small and medium scale enterprises, they were very eager to go back to work, and they work in a closed environment. So achieving good vaccination percentage is very important, as well as vaccinating their family. So with this phase, we are going into worksite vaccination. It's a very good thing that we do. And even big sectors can take up vaccinate one, donate one policy for the low income workers. It's a good thought that everybody can think about. And we also, India, we have faced many challenges by vaccinate people in remote areas. This is also very important, because in the second wave, we found more of rural population getting infected. So we have to focus on rural areas as well, vaccinating where we cannot reach easily. So we have to have a plan. And not only reaching with vaccines, we have to motivate them to take vaccine. There are several aspects. There are several hesitancy among them. So we have to give the information, encourage them, and then go ahead with vaccination. So this is the biggest challenge, I would say. We have our confused friends, misconceptions, side effects, optimism bias, etc. So when vaccine was about to reach, everybody wanted a vaccine, and that too as soon as possible. But when the vaccine was ready, it was too fast, and they're not ready to trust. And the most important thing is, what is the efficacy? Everybody wants to know about the efficacy. This bridge is only 99.99% safe. I think I'll spend. That is the tendency everybody has, especially when we had the first wave, when we had plenty of vaccines, but no takers. So we have to address vaccine hesitancy in a big scale. I think not only doctors, many public person who can take up this as in the next months, this should be the priority to spread the message and vaccinate as much as possible. So they are also worried about post-vaccination breakthrough infections. This is an Indian data which is published in April, which shows that the vaccine breakthrough infection, both with Covishield and Covaxin, is very less. And we had further data, one from Vellore, which shows that the vaccine efficacy, as pointed out by the previous speaker, is 92% to prevent severe infections, and 96% for severe infections, that is ICU admissions. You still can have mild infections. This is our own paper from KIMS Health that we had submitted and accepted for publication, where we had studied 1,322 healthcare workers, and many of them had mild infection. The infection rate, breakthrough infection rate, was 8.17%. But none, good thing is none required supplemental oxygen or ICU admission, and there was no mortality. And some are still waiting for the best vaccine. So we have a lot of people waiting for this. They are confused about choices. They are even thinking going abroad, staying for 2 months, get the vaccination, come back as a medical holiday. So they are also worried about whether this vaccine will work against mutants. So there are a lot of misconception, and probably with the information or infodemic, they are confused a lot, and they don't know which vaccine to choose, and they don't want to grab the first vaccine that come in the way. So for all of them, this is the answer. As the recent publication have shown, Pfizer or Astra, with 1 dose given for the Delta variant, you have 94, and with 2 doses are 96% efficacy. And with Astra, with 1 dose 71 and 2 doses 92. So it's important that you get the second dose, but you have good immunity against even the variants that are circulating. And the biggest challenge, overcoming infodemic about vaccine side effects. So if you think, if you say that there is a side effect, not only the family, the neighborhood stop taking vaccinating. That is a scenario. So spreading the correct information, monitor, collate all the data, and transparently report all the effect is another important thing that the media, the print should do, and the government should do, so that they get the correct information and they're not carried away by misconceptions. And the Lancet in April published this article. It is the task force that published how to manage India's second wave, taking some urgent steps. And as you can see, Dr. Rajan Kobreddy was one of the task force members. And so they had projected some points as a way forward for the third wave prevention. So ramp up facilities, ICU beds, oxygen plants, and the drugs, stock the drugs, that is important. Strengthen teleconsult to outreach all the positives and monitor to pick up those early who will benefit from hospitalization and treatment. Most importantly, uniformity in the evidence-based treatment. This is what is lacking in the first and second wave. And towards the end of the second wave, it was better. We omitted many of the useless, the drugs that was found to be useless, and even antibiotics were removed from the guideline. That's very, very important. Train the healthcare worker with the knowledge and avoid empiric antibiotic use with steroids. Manpower, ramp up the manpower, doctors, nurses, and paramedics, because these facilities alone will not help. Pediatric care is very important. We have to ramp up pediatric care specialists. If not, we have to train more doctors in the pediatric care, because we will have more ICU admissions maybe in the next wave because of the MISC, that is multi-system inflammatory syndrome. We have to look at non-COVID care like surgeries and non-infection treatment should go simultaneously, parallelly. That is very important for the patient and the economy. So we also think about our preparedness for post-monsoon infections, which are usually missed in this scenario, like dengue, leptospirosis. Medical education is affected. We know many of the doctor residents are depressed during this phase because they even miss their training, but somehow it is all managed with their rotation. But we have to give proper attention to overcome this. Otherwise, it will have a brain drain. And apart from the social distancing, avoid social gathering. That's very, very important role that we have to look at. Government has to be very strict on this testing and surveillance. Avoid travels for the next 1 year, schools and colleges, maybe for the next 6 months. Way forward for the third wave vaccination, yes, ramp up vaccine manufacture as we had calculated, and hopefully we will get those numbers. Vaccination targets per day, this is very important. Aggressive cover of the priority population, and maybe those with comorbidities with less than 45 years, because we have found many deaths in this age group also. Deploy broader mix of vaccine, fast track approval, technology transfer, these all are important. Address vaccine hesitancy, very important. This may be in various medias. Monitor, collate, and transparently report AFI. Genomic sequence is what my next speaker is going to talk about. I'm not going to touch on that. And 2020 has shown us that strong political will, building preparedness in the health system, and individual and community behavior change is all can yield powerful results. So should not allow unscientific or dangerous management practice, and that will help us a lot. So we started with the dry and run project in our hospital on January 13, 2021. And we thought that 2021 will be different. But in 6 months, we learned that we had to be patient, and maybe 2022 will be different. So from the small scale, we are going for a big scale vaccination. We should all, every private hospital I know is interested to vaccinate a large population. And bundling with this government and private, public and private, going along with the vaccination schedule, we can vaccinate the maximum in the shortest time. Thank you.
Yeah, thank you very much, Dr. Rajalakshmi. Okay, again, you have touched upon the vaccine forecasting and where our country is headed to. Although it had started up on a kind of a negative, I would say, depressing note, but towards the end, you gave us all chances to smile, and it is definitely we have a positive outlook on the whole thing. And to quote your words, let us hope that we will cross the bridge. We will not try to swim. That's what I would say. And let's hope that, just like you said, by the end of January, most of our population would be having the second dose. And by that, we would be able to achieve herd immunity. Now, thank you very much, Dr. Rajalakshmi. There are questions in the chat box too, but then, like I said, we will take the questions towards the end of, after having all the speakers spoken. So now from the private sector, we go on to the public sector. We have another very eminent speaker, Dr. Aravind R., who is the head of.
You are muted, sir.
Oh, I'm so sorry, I was muted. Dr. Rajalakshmi, thank you very much for having spoken to us. I thought you were.
Yes, sir. We heard all of you speaking about me. Yes, sir.
All right.
Last few seconds.
All right, that's all. Okay, fine. So let me go on to introduce Dr. Aravind, who is the head of the Department of the Infectious Diseases of the Medical College Trivandrum. He is the member of the State Medical Board. He is on the State Expert Committee, and he is also on the State Rapid Response Team. He is also on the State COVID Cell Committee, and he is on the State AEFI Committee. With this, it's over to you, Dr. Aravind. Kindly go ahead.
Good evening. First of all, I'd like to thank FICCI for this opportunity. And my job has been made easier by the previous speakers, Professor Gautam Menon as well as Rajalakshmi Madam. So I'll be focusing on what we have learned from the second wave. So second wave is not yet over in Kerala or in India. So it is probably plateauing because of the non-pharmacological interventions. And based on what we learned from the second wave, we need to plan ahead to face the third wave, which is definitely going to be a reality if we are looking at what is happening in UK and rest of the world. So Kerala believes in learning from examples in what is happening from across the world. So this is basically a snapshot. Now, if you look at January 2021, so we were sitting pretty well at that point of time, even though we had, say, around 10 lakh cases. The zero prevalence, which was done by ICMR, put our zero prevalence at, say, 11%, and which was done by our state government, put the zero prevalence as around 10.6%. So you're having, say, around 10 lakh cases, and your zero prevalence is, say, 10.6, means that you have missed only, say, so out of 3 cases, you are picking 1. That is actually a pretty good statistics. But the problem was that, so we were successful in protecting 90% of our population. But if we are looking at it in another way, 90% of the population were vulnerable to a new variant. So that is actually what has happened in Kerala. But then in 2020, we were having very stringent measures, and we were successful in bringing the zero prevalence to only 10%. But we had put all our eggs on one basket. That is, by January, we thought that we will be able to vaccinate to the tune of around, say, 2.5 lakhs per day. So just like what Israel did, we hope that within, say, 2 months, we would have been able to cover almost all the vulnerable population. But then due to the break in the supply chain and all, so we had to take the second wave head on. So we could not vaccinate all the population we actually wanted to be vaccinated. So this is the story to begin with. And then from January onwards, so from October, that was our first peak, then we had a plateauing. So we never touched the baseline, because the peak in October, the number of cases maximum per day was only around, say, 15,000, and our TPR never crossed 15. But then from April onwards, you can see that our TPR, say, sort of became around 30, and now, as of now, we are having, say, around 27 lakh cases, and even though the case fatality rate is still low, but the number of people who have died has become around, say, 12,000. So this is the problem. So we had to take the second wave head on, because we could not use that window of opportunity. So that is the January, February period. If we are able to vaccinate more number of people, probably we could have been able to bring down the number of deaths. That we were not able to do. So taking taking the knowledge from this bad experience. So prior to the third wave, before the third wave hits us with a new variant, so we need to ensure that all our vulnerable population receive at least one dose, probably both doses. So this is why the second wave happened. That is because of vulnerable population. 90% of the patient population in Kerala didn't have immunity against COVID. then because of waning immunity. So we know that there is an antibody decay kinetics, and it will protect you for around say 6 months to 8 to 9 months. After that, you are prone to reinfection, and because of variants of concern. So usually we think that if it is due to this waning immunity, so usually there has to be a periodicity between waves of say around 3 to 5 months. But if it is due to a new mutation, like what has happened in UK, so just after this alpha wave, now they are having the delta wave, and delta wave has picked up a new mutation, that is the K417N, which they have borrowed from the South African variant, which is an immune escape mutant. So these viruses are one step ahead of us. So the only armamentarium that we have as of now is to vaccinate maximum percentage of our population. And definitely that is the need for the social vaccine. There's a variant behavior. So we know that the elections across India did play a major role, as well as the dropping of guard. So we need to see that such things do not happen in future. And this is our own data, which showed that after 6 months, only around 33% of the infected people are having antibodies. So definitely there is a waning immunity, what you refer to as antibody decay kinetics. So we need to be on the alert for the fresh waves of the pandemic. And the one advantage of Kerala is that right from November, December onwards, we have been sequencing samples from all the districts. We knew that only by doing that we can be one step ahead of the virus. We need to know what the virus is doing. We need to know the variants of concern, the variants of interest that the virus is adopting to escape the immunity and all. And this is actually the data from April. You can see that the blue one is the alpha strain, that is the B117. So initially the second wave in Kerala was triggered off by the alpha strain, and you can see it from January, and within say around 2 months, 30% of isolates in Kerala became the alpha strain. And you can see that the yellow one, that is the B1617 genome, that is the double mutant, or what you call now the Delta variant. So in April, actually 7% of our isolates happened to be due to that Delta strain, and 30% was this alpha strain. And this is how the wild strain, which was the predominant in Kerala, was replaced by the alpha strain. That is over. So 2 months time, the alpha strain had become the dominant population in Kerala. But interestingly, over the next 2 months, you can see that the alpha strain has been replaced by the Delta strain. So in USA, in UK, they had this second wave due to this alpha strain, and now they are having this third wave due to this Delta strain. But interestingly, in Kerala, so we are having the both of these fused together, because during the second wave itself, you can see the alpha strain has been replaced by the Delta strain in almost all the districts in Kerala. So you can see that the light peach is the Delta strain, and that has almost replaced the blue thing. And this is the data from the last month, updated up to 2/6. You can see that the major variant of concern as of now in Kerala is the Delta variant. This is very, very important, because we know that Delta variant is more transmissible. It is having a transmission advantage of around say 40 to 64% over the alpha strain, and alpha strain is having a transmission advantage of over 40 to 70% over the pre-existing wild strain. And if you're looking at the immune escape mutant, so if you're vaccinating in their population also, the virus can get away from the neutralizing antibodies, but then that won't result in severe infection or death. So you may get a mild infection or a moderate infection, but you are not going to die. So even if the variants of concern develop mutations like this K417N, that is what is happening in UK now. That is, the Delta strain has acquired a mutation known as a K417N. That is an immune escape mutant, and they have termed it as Delta AY1. So if you look at the data from Kerala, this is already present in Kerala. It's not from the Delta AY1, because the South African variant was there in 5% of the isolates. And now we are having 2 or 3 cases where this mutation has been transferred over to the Delta variant. So this is actually something which we need to keep a close track on. So that is why the state is doing sequencing on a monthly basis. We send say 140 isolates from each district, so that we get to know of all these mutations, so that we can plan strategies accordingly. And what should be done to based on our experience from the second wave, how to prepare for the third wave? The most important aspect is continued aggressive vaccination. The second aspect is containment efforts to limit the spread, because from the experience of UK, we know that vaccination alone is not going to help. Initially, we need to have pharmacological interventions as well, so that our hospital system do not face the brunt of this third wave. Third is continued genetic sequencing and molecular contact tracing. Even though the Kerala is doing it pretty systematically, we need to increase the number of samples which are getting sequenced, because as of now we have identified only a couple of cases where K417N the variant is there in Kerala, but then UK Delta variant happens just 1 month back and now have identified around say 60 cases, because they are sequencing around 5% of all the isolates. So we need to increase the number of isolates which are being sequenced, and we need to say invest more in this molecular contact tracing. And the fourth aspect is the social vaccine, the back to basics, whatever it is, your mask, none of the variants can penetrate your mask. So you need to practice this SMS, tracing, quarantine, testing, isolate, and treating. And then demand-based real-time infrastructure and logistics upgradation. So Rajamanikam sir did say that Kerala did not face an oxygen shortage. It was because of meticulous planning. So we need to have such sort of demand-based real-time infrastructure and logistics upgradation. And this is a snapshot from what happened due to the alpha strain in England. So so the first time it was identified in October in England, and by January, 98% of the isolates in England were replaced by this alpha strain. And now you can see that alpha strain has been replaced by the delta strain. So definitely the viral fitness, when the viral fitness increases, there is increase in transmissibility or there is an increase in virulence, the previous strain will be replaced with a new strain. So we should be on the lookout for that, and that is what has happened in Kerala. The alpha strain has been replaced by delta strain, and we need to see whether the delta strain with that K417N the variant is going to become dominant, because it is an immune escape variant as well. So this is the figures from the Public Health England showing that in order to contain the pandemic, this is what they did with the alpha strain. You need to up the number of vaccinations delivered per day. So the maximum benefit was obtained when they are giving say 2 million vaccinations per week, along with very stringent non-pharmacological interventions. So when can we lift the restrictions? This important thing. So you can see that the UK had, so during the alpha wave, they had this lockdown in place for say 3 months or so. When they tried to lift the lockdown, that is, they had phases of this unlocking, you can see that there is a surge in the number of infections. So this is also very, very important. So you need to have background data to see what is going to happen when you are going for this unlocking in phases. And then this is a most positive story. This is the Israel story. So they were able to vaccinate around say 60% of their population in a breakneck speed. You can see that once the vaccination, there is a blue graph picked up, the number of infections came down drastically. The number of deaths also came down drastically with when the vaccination rate picked up. The hospitalization as well as the R0 as a reproduction number also came down drastically when the when the percentage of population vaccinated increased. You can see that the hospitalization rate also come down. So definitely shows that the way in which we should be prepared to tackle the third wave is by upping the vaccination rate. We need to cover maybe around 60 to 70% of the population in breakneck speed. And this is from our dashboard. So Kerala, everything is displayed in the state dashboard. We can see as of now we are having say around 27 lakh cases, and the case fatality rate of around 0.41. And the most important thing is that even though we have administered around say 89 lakh doses, only 25.1% of the population has received one dose, and we have given 2 doses of vaccine only to around 8% of the population. So these numbers have to be to increase rapidly. So the state has a plan of vaccinating so around 2.5 lakh people per day. But most important aspect is that in February also we did have the same plan of vaccinating 2.5 lakh. So that is where we faltered, because there were problems with the supply chain. The only way out is to somehow up the vaccination rate. And Trivandrum and Ernakulam, we have more than 1 lakh persons vaccinated, but then that is not enough. We need to have around 60 to 70% of the population vaccinated. So the next thing is we say that the pediatric wave is going to hit us, and regarding the pediatric wave, the virulence in the pediatric population is not going to be high. The only thing is that when 3,400 kids get affected, one kid develop the multisystem inflammatory syndrome. So when you are having more number of pediatric infections, we need to be on the lookout for more cases of MISC, and the state has issued guidelines, and we have upped the infrastructure for the pediatric ICUs, everything. And we have plans of training these adult physicians to take care of pediatric patients as well. So, and the protocols and all these things are in place to tackle this pediatric wave. So thank you very much for this opportunity. Thank you.
Yeah, thank you very much, Dr. Aravind R. after the first two speakers, you actually touched more of on the genomic side and, the strains that are currently in prevalence. And again, to see the good side of the story, I feel that the Delta strain, after the Alpha strain, the Delta strain has come, which is about 7.31% that you said. But since the Delta strain has also come into the second wave, let's hope and pray that, we will not perhaps go for a third wave. But I'm sure that people at your end are working on the genomic side. So the genomic sequencing and the molecular contact tracing and all that would probably help. And as a representative of the testing side, we have one of the largest testing facilities in Kerala in the private sector. I would say that when you showed the Kerala dashboard, it is very interesting because the Kerala dashboard it's always this is actually this is for the public that I'm saying this, because there is always this question of saying, like, is the government really bringing out the real figures? And I would say that the government is really bringing out the real figures. The government is not hiding any facts to the story, because when you look at the figures that we upload every day onto the government portal, it is more or less in sequence with what the government is putting out every day. So I think we have hope for the future, and like the previous two speakers said, if we can get everything in place at least by coming January or the end of the year, I think we will probably be more on the Israel route. Let's hope so. For a country as large as ours, that would be very, very good news. So thank you all three speakers for having been with us today evening. Let us kindly bear with us for some more time, so that we'll have the other two eminent speakers also address us, and then we will go on to the question and answer session, because there are lots of questions coming into the chat box. Thank you. And I would now request that we go on to Dr. Anirban Om Chowdhury. Before we go, and his topic is slightly different from the other topics that we have now discussed. Dr. Anirban is actually going to speak to us on the clinical perspective of the utility of the interleukin-6, so the IL-6 and the PCT in the management of COVID. Dr. Anirban, let me just introduce him. He is currently the professor and critical care expert of the GB Pant Hospital in New Delhi. He has an MBBS and an MD in anesthesiology, and is a fellow of the Indian College of Critical Care Medicine and a postgraduate diploma in medical law and ethics from the National Law University in Bangalore. He is also professor and ICU in charge of the GB Pant Institute, like just I said, and he is also teaching anesthesiology and intensive care in the Delhi University. He is a subject expert on anesthesiology and anesthesiology and the National Board of Examinations in New Delhi. He is an examiner for FNB Critical Care, the National Board of Examinations New Delhi, and a nominated member of the Expert Committee DCGI New Delhi. He is principal investigator of ICMR, and he is on the editorial board of International Journal of Health Research and Medical Legal Practice. And he is a member of many professional bodies. He is the executive committee member of the Society of Critical Care Medicine in Delhi and NCR, Indian Society of Critical Care Medicine, Indian Society of Anesthesiology. And he has many books and papers published to his credit. And he has won several awards. He's won, to name a few, he's won the Honor of Excellence by the Indian Society of Critical Care Medicine in 2016, Fellowship of Indian Society of Critical Care Medicine in 2017, ACP Award at Asian Conference of Pharmacoepidemiology in Hong Kong in 2013, ESOP Award at the 4th NWAC World Anesthesia Convention in Bangkok 2013. These are just a few. And with this, let me introduce to you Dr. Anirban Om Chowdhury, and it's over to you, sir, for this very interesting topic.
Thank you, sir, for your, am I audible, sir?
Yes, you are. Yes, you are.
Thank you, sir, for your kind introduction. And of course, I was listening so attentively to Dr. Arvind Raghuram, and just to realize and to reinforce that thinking that probably we have to continuously, simultaneously learn and unlearn things as we walk along this journey through the COVID. Because so many things that seemed so obvious last year seems so frivolous now, because our understanding of the disease has changed so drastically that, and even with this Delta plus variant, which government has announced today, I think it is said that that it is even resistant to the monoclonal antibody, Regeneron therapy. So anyways, I would like to restrict myself to the clinical scenario which we have encountered during the second wave, in which we were as badly as hit as Kerala were, especially in the end of April and May. So let me start with this hypothetical case. Although it's hypothetical, it is in real sequence because such cases were encountered day in and day night by all the intensivists. So this is a 55-year-old male who had mild fever, malaise, and sore throat for 3 days. So obviously, patient was tested for RT-PCR, found out to be positive. The CBC was advised alongside, which showed normal values. So anyways, the patient was started with favipiravir, doxy, ivermectin, PCM, and other supportive medications, advised for home isolation with self-monitoring of symptoms and monitoring of oxygenation by using a pulse oximetry. All along this, on day 4, patient becomes febrile. The temperature rises up to 101.4. There is increase in respiratory discomfort. The saturation falls below 90% on room air, and the patient rushes to the emergency. So thankfully, this patient was lucky because not two patients were getting bed that easily in the hospitals. So this patient was able to manage his bed. So patient was admitted in the ward. Oxygen supplementation was started by mask. The biomarkers were sent, and patient was monitored in the hospital setup. So the biomarkers report show that everything was elevated. CRP was very high, D-dimer was raised, ferritin was very high, LDH, CBC showed lymphopenia, which was earlier normal. Now, how do we modify our treatment plan and prognosticate the outcome in this patient? To understand that, we have to realize that COVID is not just a localized respiratory infection, but it is rather a multi-system disease where there is a complex interplay of the various immunological, inflammatory, and coagulative cascades to a variable extent. And because it is variable, according to the host immune system, and because of the genetic and acquired differences in this system, there is a wide heterogeneity in the manifestations, course, and outcome. And we have all witnessed it in our routine practice, that the kind of manifestations that output even from members of the same family are often divergent. Someone behaves so smoothly all across the treatment, while it's with all the tumultuous course. So because of this wide heterogeneity, clinical judgment alone often falls short. It is often inadequate. That, of course, doesn't mean that we would rely only on investigations, but if good clinical judgment is supported by a good characteristic that can objectively measure and evaluate an indicator of normal biological and pathological processes or pharmacological responses to treatment, the job of the physician, no doubt, becomes much easier and moves on the right track. And that help comes from the biomarkers. So probably in all important areas where the clinician might face a challenge or an obstacle, these biomarkers have the potential to aid in clinical decision making, like in the early suspicion of disease, classification of disease severity, for framing criteria for ICU and hospital admission, identification of high-risk cohorts, rationalizing therapies and assessing their responses, predicting outcome, and also framing the criteria for discharge from the ICU and hospital. So various biomarkers are in different levels in their trials. Some have been approved by the FDA or in the different stage of their approval. But it is to say that since this entire process is a continuum, no single biomarker can be assigned to perform all these functions. And we have to take a mix and match out of these available biomarkers based upon their availability, based upon the evidences, and based upon our comfort in using or interpreting them. But the primary thing, of course, remains a good clinical observance. So as we can see that in our patient, the disease has progressed from mild to the moderate severity over a period of 4 to 7 days. Now, as we continue, we find that on day 5, the saturation further dips. So the patient is put on BiPAP with an IPAP of 12, an EPAP of 6, a 5 of 0.6. Patient is made prone for up to 12 hours a day. And gradually, because we have crossed 5 days, the patient is taken on steroids, low molecular weight heparin, because the D-dimer is already raised. And by the day 7, the patient shows signs of stabilization, or rather patient is not worsening. So the patient becomes afebrile by day 9, requires oxygen by non-rebreathing mask and intermittent BiPAP. Doesn't depend entirely on BiPAP, but when we see the biomarkers and we try to compare with the previous reports, we find that still they are high. The CRP has come down, the ferritin has come down, but still they are consistently above normal. Meanwhile, the chest CT was done, and the severity score is also found to be moderate and of 16 out of 25. Now, the second question that is more perplexing and intriguing to the physician at this stage is that what is the risk of cytokine storm, and what would be the role of IL-6 as a predictor of the cytokine storm? Is this patient going to behave smoothly and come out of this disease process, or might have even a tumultuous course? Now, again, one important thing we have to understand is that the SARS-CoV-2 infection triggers both innate and adaptive immune response. The innate immune response is manifested as an excessive pro-inflammatory response, while the adaptive immune response leads to a dysregulated host response, both of which ultimately result in tissue damage, leading to multi-organ dysfunction and multi-organ failure. Now, cytokine storm, which is the hallmark of the SARS-CoV-2 infection, evolves through several pathways. Particularly important is the JAK-STAT. The JAK-STAT is the Janus family of kinase. So this pathway, which activates the macrophage activation pathway, leads to the release of IL-6 and TNF-alpha, and this is probably muted through the adaptive immune response. Now, the large-scale unregulated production of IL-6 further stimulates the downstream pathways, which is muted by the innate immune response, leading to the increased production of CRP. So whereas we get both elevation of CRP and IL-6, because it is the former, that is the adaptive immune response muted by the macrophage activation pathway through IL-6, that is leading to a release of unregulated production of IL-6, aggravating the production of CRP. So probably the rise of IL-6 occurs much earlier. So as we see the various stages, as we move, although in reality, we don't find such smooth tapering and smooth elevation. But as we know that it is the inflammatory response from pulmonary stage to the hyperinflammation stage, which is responsible for the cytokine storm. And this is the time when the immune response is gradually phasing down and the inflammatory response is gradually picking up. And therefore, at this stage, it is probably more reliable to look upon this particular markers that are getting elevated as a part of the inflammatory response phase. So if you look into the time course of these markers, and if you are dealing with the patient before 7 days of the onset of symptoms, probably we are relying on the TLC to some extent, on the lymphocyte count will be normal or slightly low, to LDH, AST, ALT, CKC, KMB, which all may be raised, and maybe early markers of disease severity to mortality. But as we approach towards the hyperstimulation phase, where the inflammatory response is getting provoked, then the total leukocyte and lymphocyte count progressively falls to reach a nadir at 8 to 9 days. Thrombocytopenia may occur, and it is where that IL-6, IL-10, etc. starts rising. And beyond 14 days, it is again, there is an increase in the TLC, lymphocyte, and platelet, which can predict recovery, while the reducing count predicts mortality. So in our patient at this stage, when patient is on day 9 or day 10, a rise of IL-6 may be a predictive of increased cytokine, of increased risk of CRS. And if we look into the literature, we find that more biomarkers testing during this phase between the patients, between the second to the third stage, helps in building a scoring system for the prediction and guiding a proper timely treatment. And we also see that if there is early elevation of CRP of more than 100 and IL-6 of more than 65, followed by an increase in high sensitivity troponin of more than 30 and D-dimer of more than 960, then that is significantly associated with severe disease and also with mortality. So if we look in terms of the short-term prognosis, again, it comes to, we have to note that increasing concentrations of cardiac troponin I, D-dimer, CRP, and LDH are all associated with short-term mortality, where Probably cardiac troponin I provides better mortality risk prediction than CRP, but the differences with D-dimer is non-significant. Higher D-dimer values and especially higher CTNI are consistently related to an increased prevalence of older age, serious risk factors, etc. And therefore, they have to be taken with a pinch of salt whenever we are dealing with patients who have such factors in place. So while on IL-6, we find that this IL-6 comes from the variety of sources, from the T cells, from the endothelial cells, from the fibroblasts, macrophages, the monocytes, act upon the specific receptors, both the soluble IL-6 receptors as well as the GP30, targets the B cells, T cells, neutrophils, eosinophils, basophils, leads to the proliferation of B lymphocytes, their differentiation and production of antibodies. On the T cells, it produces cytotoxic activity. In the liver, it leads to the acute phase protein generation and the hematopoietic stem cells where it stimulates the growth differentiation. So the CRS becomes a key effect of these molecules alongside atherosclerosis, alongside leukemia, hypertension, COPD, and participation in various malignant tumors like pancreatic cancer, gastric cancer, etc. So the entire gamut of influence of IL-6 is so varied and so wide dimension spread over so many things that it is not possible to guess that what is leading to what. Therefore, it is very important to realize that when we are dealing with a COVID patient who is having acute inflammation, and in the setting of those acute inflammation, IL-6 is going to produce a steep rise of serum amyloid, antitrypsin, thrombopoietin, etc., which further increases the vascular endothelial activity because of endothelialitis, leading to increased vascular permeability, all of which finally leads to an increased production of fibrin and formation of fibrin clot. So if you are able to, at the right time, to use the IL-6 blockade, probably if the timing has to be the proper, then these immunotherapeutic implications may fulfill to a certain extent and limit the spread of the cytokine storm. We all know that tocilizumab was not available during this. It was very difficult in getting tocilizumab during the second wave. So we relied much more on the other tocilizumab and the bevacizumab. So, but the one thing which remains is that that tocilizumab binds both cell surface IL-6R and soluble IL-6R, others do not. And therefore, probably toci may have an edge over others if we are able to use it at the right time. So there are a lot of immunotherapeutic implications of IL-6 which are already approved, like rheumatoid, juvenile rheumatoid, this Castleman's disease, etc. But these were not of much concern, but probably have got more expression and much retribution after the onset of COVID. So there are also candidate chronic diseases where its importance has been studied and has been relied upon, but not to an extent where in a pandemic-like situation, probably it is the first time when we have encountered. And that is also to an account because IL-6 is expressed for a longer period than other pro-inflammatory cytokines, and that has made its usage easier during the first wave. If we look into IL-6 as a biomarker for development of fatal severe acute ARDS or the CARDS, COVID-associated ARDS, IL-6 behaves as a better predictor of disease progression and was the most significant predictor in the non-survivors group. So particularly if we are dealing in those who are having mortality high, probably a raised level of IL-6 makes prognostication easier when compared to age and CRP. Another interesting thing we have found that, which RELO have reported, that there are 5 phenotypes which we ranging from the most benign, which is phenotype 1, to the worst phenotypes, which is phenotype 4 and 5, having florid CARDS, COVID-associated ARDS. And IL-6 has been suggested as differentiating feature between phenotypes 2 and 3. So probably more aggressive treatment can be initiated for phenotypes 2 if such a patient is having certain other comorbidities that may make treatment difficult at the later stage. And this is a very good study which tried to compare and try to see both IL-6 and IL-10 independently and together as predictors of disease severity in COVID-19. And they found that although the accuracy of IL-6 and IL-10 were not much of different, and the sensitivity with IL-6 was high, and the specificity was higher with IL-10, but when the two were combined, their accuracy stupendously increased, and their sensitivity as well, and the specificity was almost 100%. So this is something which needs to be explored upon in future to understand. Now let us go back to our case. As we progress by day 14, the patient has improved with all our therapies. The saturation becomes 94% on room air. So we shift the patient from ICU to the ward. We taper down on the antibiotics because after day 7, when we had started the antibiotics and after day 7 because of the steroids, and by day 18, again the patient's saturation dips, that is the SpO2 comes below 90% on oxygen by mask. Patient comes back from the ward back to the ICU. There is hemodynamic worsening, altered sensorium, they're requiring mechanical ventilation and also requiring the inotropes. The TLC shows a 13,000, lactate goes up, the CRP is still above 100 or it is just on the 100. Now the question again comes that what is the role of PCT or procalcitonin during antibiotic de-escalation and prevention of secondary sepsis? Now secondary sepsis is something which have shown so many different colors, especially during the second wave, that it becomes really a scary situation for at times for us when we were using the steroids beyond certain number of days, because the fear of this patient going into secondary sepsis becomes alarmingly high and often beyond the course of prediction for a clinician. And we are awakened at the middle of the night by our resident on duty saying that, sir, this patient is going on to sepsis. Now, the role of co-infections on secondary infections in COVID-19 has been studied in details, and there are a lot of papers available widely in the literature, and where everyone recommends empiric antibiotic therapy, and the relevant bacterial pathogen also varies from place to place, but they are no different from the ones we are normally seen. The community-acquired pneumonia patients will have the kind of infections they have. The same patients are also infecting them. So this way, the PCT has role in preventing overuse of antibiotics. And if we see this was a meta-analysis which was published during February, and which had showed all the bars show the diamonds are towards the right, which means that elevated PCT levels could identify a subset of COVID-19s who have increased risk of severe disease and adverse outcome. But the problem was that because of low sensitivity and undefined cost-utility ratio, its limitations were less. Whereas during the first wave, we had witnessed that we did not rely much on PCT because we know that in any viral infection, PCT won't rise. But during the second wave, when we were offset by this the problem of secondary infections, PCT, the role of PCT was studied. And again, this is another study which combined interleukin-6, procalcitonin, and the neutrophil lymphocyte ratio, and found that IL-6 was the most accurate inflammatory biomarker, and it has a particular cutoff, which could classify more than 90% of patients with the risk of severity, with an area under ROC curve of 0.9, which is close to 1. And the secondary and bacterial fungal infections expressed in high level of PCT are also associated with severe and potentially fatal forms of COVID-19, and their cutoff levels was much higher. So if we can choose the PCT test after 10th day or 12th day, probably we will be in a better position to predict those diseases. And not that the least, the procalcitonin as an antibiotic stewardship, it has been found, it can guide us to de-escalate therapy, significantly reduce antibiotic usage by 2 days in COVID-19 patients. How big difference it makes, I am not sure, but in a pandemic, even a single day matters. The role of procal in antibiotic decision-making in COVID-19, again, it reduces the result of unnecessary antibiotics. And another important observation was found that significant association between PCT and de-escalation to oral therapy, that even if you don't stop giving antibiotics, you convert them from parenteral route to the oral form. And even that helps because that eases out the patient's movement. So this is something which people worked out in Canada, and they tried to see that whether these patients require antibiotics or not, based upon the clinical presentation, radiological findings, and the blood tests. And when it was not unequivocal, then they considered a PCT value of either 0.25 or less than 0.25 to decide whether to continue or to stop antibiotics. So this is something people have worked out. Such a working formulation can be helpful in scenarios, but it cannot be a one-size-fits-all. It has to be created into that particular setup. And most of the recommendations that choose PCT suggest strongly discourage antibiotics beyond when PCT is less than 0.1, strongly encourage procal when it is more than 0.5, and between 0.1 to 0.5, it is somewhere it comes with a pinch of salt, where 0.25 is the borderline where antibiotics are discouraged and beyond which antibiotics are encouraged. Now, if you see that the rates of bacterial infections and antimicrobial use in COVID-19 on a retrospective study, one important observation that we should make is that the co-infections with Enterobacteriaceae aspergillus were common, although aspergillus is not detected in such a high level in our place, but many people have. But what is important is that the blood culture collected at admissions has a very, very poor diagnostic yield of only 4.2%. And that is worrisome because we don't have enough time to keep this patient's life on a ventilator or on a particular drug. We need to do something. And bacterial and fungal co-infections are rare and they are mainly prevalent in the critically ill patients. So these are something new, that computer-aided prediction and design of IL-6 inducing peptides, because IL-6 plays a very important role in the progression of many diseases. And if we are able to pick up those particular peptides which are specific to COVID, then probably our job will be much easier. But still, probably we have a long way to go. And another is the cytokine profile before and after immune modulation, which means that in hospitalized patients receiving TOSI, if we go into the IL-6 and IL-6, probably we can see the kind of immune effect that which produces the immune escape at a later stage can be easily understood. And if you see this slide, we can see that the most common cytokine elevations among all patients includes IL-6, SIL2R, and IL-10. And those patients, when they received tocilizumab, their IL-6 came down at a much higher rate, as you can see from the second slide, in comparison to whom it did not. Therefore, the prior elevation of IL-6 before receiving tocilizumab or this prior is an important criteria to understand its response. So there are numerous pitfalls and challenges during clinical monitoring because COVID-19 patients sometimes lack many of the hallmarks of the cytokine storm, and such hallmarks can make the problems for a clinician. The clinical course of CRS is much more acute after COVID-19 than after other, because CRS has been found to occur after sepsis due to other causes, but not in such an acute manner where the patient has deteriorated within a span of minutes to hours. And therefore, IL-6 levels are important in that scenarios. And highly selective and potent ADAM17 inhibitors like A17Pro, they are expected to be more effective in suppressing disease states related to IL-6 trans signaling with a few adverse effects. So at the end, my take-home message would be diagnosis in the first week of illness is established by molecular testing, no change in that in our knowledge. Asymptomatic or mild category without underlying comorbidity, no investigations are required. Mild category with associated comorbidity or patients with moderate category, we go for further tests, CBC, CRP, creatinine, LFT at admission. If any of these markers are abnormal, further investigations should be considered as required in the patients for severe category. If symptoms persist in the second week, CBC and CRP should be repeated to see the trend and monitor, decide monitoring and further investigations. In the severe category, in addition to these previous markers, PT, APTT, INR, serum ferritin, D-dimer, as well as cardiac biomarkers are advisable. In the critical category, IL-6 and serial lactate in addition to all others. To monitor a hospitalized patient on therapy, CBC and CRP should be repeated 48 to 72 hours after admission or earlier, although the decision can be taken by the clinician, again, based upon his clinical expertise and availability or logistics. Clinical evaluation is of paramount importance, and not to forget that, because particularly during the second wave, what we have witnessed is that WhatsApp circulation of prescription, online doctors are advising, and patient-to-patient circulation of prescriptions. So patients are not doing tests, trying to somehow get hold of the medicines here and there and try. So these are very much alarming and create a lot of sense. And also an important aspect is the antibiotic de-escalation to be guided by PCT. Thank you very much for your patient hearing, and I hope I'm able to do justice to this topic.
Thank you very much, Dr. Andreban Chowdhury, for that enlightening speech on IL-6 and PCT, and how it can prevent the cytokine storm and also reduce the incidence of antibiotics on the patient. Thank you very much for that very, very explanative subject on testing. And I'm sure that, many of our the people listening to you have many doubts on that. But due to lack of time, we are going on to the next speaker, Dr. Sri UK Anantha. Before I go on to him, let me just introduce him. Mr. UK Anantha Padmanabhan is a member advisory board of the MGM Healthcare Chennai.
By the phone up.
And during his long career of 3 decades in the healthcare industry, he has held various top leader positions in large hospitals like Apollo Hospitals, Kowai Medical Center and Hospital, Continental Hospital, Meenakshi Mission Hospitals, etc. He is planning and designing healthcare information technology solutions with emerging technologies like Internet of Things, IoT, cloud computing, artificial intelligence, and machine learning. This has been his forte. He's also the director of a healthcare IT startup company, Tenx Health Technologies Private Limited, based in Coimbatore, which is involved in design and implementation of hyper automation solution to hospitals. He's actively involved in teaching, training, and research in the field of management, and is a visiting faculty for many postgraduate institutes and universities. He's a graduate in electronics and electrical engineering with postgraduate qualifications in business management and hospital administration from LIBA. This is Mr. UK Anantha Padmanabhan for you. Over to you, sir.
Thank you for such a generous and kind introduction, sir. Maybe are you able to hear me?
Yes, we are very much.
Yeah, maybe I'm a little odd man out, but what is very satisfying is that Rajamanikam, during his inaugural address, talked so much about hyper automation and emphasized the need for hyper automation in healthcare facilities. So quickly going through some of the lessons learned in the COVID-19 pandemic and how it accelerated technology adoption in hospitals. COVID-19 was unprecedented and hit us like a tsunami. Patient loads in the hospitals increased by 400%, and Indian medical infrastructure almost crumbled under pressure. Indian healthcare, which was ill-planned and poorly funded for over 70 years, was very vulnerable. We know that many lives and livelihoods were destroyed, and it changed the way we work and we live. It brought to focus the need for agile, flexible, and cost-effective, health-efficient healthcare facilities, and it accelerated the technology adoption in hospitals. I think the whole story of hyper-automation started with me and with my hospital because of COVID-19 pandemic, when oxygen supply management became very, very critical. The managers, operations managers, the doctors, the ICU specialists, even laboratory people wanted to know how the oxygen is managed, how are we getting oxygen throughout the day and night, and they had to have real-time information, like the oxygen management ward room in the state. They wanted to know in the hospital, when was the oxygen coming, in what form it was coming, was it coming in liquid oxygen form, or was it coming in A-type cylinders, B-type cylinders, D-type cylinders. They wanted to know it all. But that was one call. And secondly, the air quality and air conditioning systems in ICU also created a situation where people could not get inside the ICUs too often, but they wanted to know the air quality, they wanted to know the temperature, humidity in all those places. And so that's where the hyper automation also really helped. And they wanted to manage equipments in the hospital. They wanted to manage some of the ICU equipments like ventilators, monitors, infusion pumps, and all that in the hospital because the ICUs were overflowing. Then next one was the managing ambulances. The COVID ambulances, we had about 5 or 6 ambulances. We had to track those ambulances. We had to really find out who was the technician who was going in, how many kilometers was it running, and where it was going. We had to track all the ambulances. And then we were getting medicines in huge quantities. When we were getting medicines in huge quantities, we had to receive them, we had to account them, do the distribution, and that was another issue. The last but not least, patient tracking, social distancing, all these put together, I think made us talk about digitization, complete digital transformation. As the CEO of Accenture said that more than 50% of the Fortune 500 companies disappeared after 2000 because they did not do digital transformation. But what is hyper automation? Hyper automation is intelligent or hyper automation is the application of advanced technologies like artificial intelligence, robotic process automation, Internet of Things, real-time location tracking, and no-code platform software for automating all processes in the healthcare facility to augment human effort and ensure operational excellence. And it is about helping the technicians, it is about helping the doctors, it is about assisting the nurses in their effort. And to me, for people like me who have been involved in the hospital operations for a very, very long time, we have seen operations happening manually. We visit the ICUs, we keep visiting the operation theaters, the ward stations, talk to doctors, and we have seen the operations happening manually. But we felt, people like us felt that hyper automation or intelligent automation is a magic wand in the hands of the hospital administrators and managers, but they must be ready to bite the bullet. I think that is very, very important. That is very, very important. We must learn to look beyond a hospital information system, EMR, fax, and telemedicine. I think that is very, very important. What are the technologies in hyper automation? Low-code application platforms, Internet of Things, robotic process automation, real-time location tracking systems, and artificial intelligence. For your information, there are about 20 technologies in healthcare information technology, but these are all the 5 top emerging, cutting-edge, innovative technologies where really come together to make hyper automation. But I think when I dissect this, the definition of hyper automation and intelligent automation, I think I can make a distinction like this. The hyper automation is the convergence of all these technologies, but the intelligent automation is not only convergence of these technologies, but artificial intelligence being the centerpiece of the entire automation. This low-code application, I don't know how many of you have really used this, but this came very, very handy during the COVID situation, where when a lab doctor or maybe a physician or an intensivist asked us to write out a program, write out an application for his workflow. For example, COVID vaccine administration, we could just write an application, IT application, in a matter of about 4 or 5 days. So an application platform that supports rapid application development for one-step deployment with a high level of programming abstraction. All business owners will be able to build their own IT applications, and they will be called citizen programmers. Can you believe tomorrow doctors will be programmers, nurses will be programmers, lab doctors will be programmers. There will be very little dependence on the IT professionals. It is predicted by Microsoft that 65% of the software applications are expected to be on low-code application by 2025. Typically, a company like Zoho Corporation, an Indian software company, has a very good low-code application platform, and it finds a place in the Gartner Magic Quadrant. What are the low-code applications which we have been able to have during the COVID situation? We were able to develop building management, asset tracking and monitoring, environmental monitoring, transportation management, workflow management, quality and safety management, and business development. Why low-code platform? They require very little coding effort, IT skills, but very good domain knowledge. If you want to do it for a lab, you must have enormous knowledge about the laboratory functioning. If you want to do it for intensive care, you must have the full understanding of the workflow in the ICU. But it is 10 times faster to develop the software application. It is 50 times cheaper than the conventional software. Very less time is required for training and implementation. And there is a concept of evolving, a concept of citizen programming evolving. And I predict that in the next 5 years, low-code software skills will be one of the necessary conditions for employment. Robotic process automation, again, this came very handy. This robotic process automation is a software-based technology which is used to produce software robots to emulate human execution in business processes. It captures data, runs applications, triggers responses, and communicates with other systems to perform variety of tasks. It is very useful for automating routine, large volume, low value, time consuming tasks. For example, when you want to register about 500 Covaxin or COVID Shield patients for inoculation, when they come here, we can use this RPA very effectively. And it is an unsung hero in the hyper-automation toolbox. I think, but in US, almost about 50 to 60% of the organizations have started using robotic process automation. But in robotic process automation applications in healthcare, what we are using right now in this country, we can process all the service invoices for maintenance, marketing, and all that. Then we can prepare automatic goods GR. Suppose we get 1,500 varieties of drugs and materials in the hospital. We can prepare the goods receiving note without having to have about 5-6 people working on it almost for 8 hours or so. This robot will do it in the night and keep it ready in the morning. Already Rainbow Hospitals in Hyderabad is using, Max Healthcare is using. We can process insurance claims, 1,000 insurance claims in a month can be processed through the software robots. Outpatient registrations up to about 15,000 registrations can be very easily done using this RPA robots. Then data migration in healthcare, we were able to migrate 30,000 patient records in 10 days using this RPA when we migrated from one vendor to another vendor, which otherwise would have taken at least about 1 month with about 10 people entering the data into this. Then email processing and classification, download attachments, and even service provider credentials. Suppose we have a doctor, we have a nurse who comes into the hospital and we need to do service provider credentialing. This robotic this tool will go to the website, check his qualification, check the certification he has done, and do everything what an HR person will do. This is the roadmap. This is the broad framework of RPA. It is very interesting to see a robot. Robot is like a genie, in a bottle. So this mobile mail robot will receive the mail, then it will do the data extraction, it will go to the rules engine, then develop this dashboard, then it can also process for payment. And maybe I don't want to talk much about it because of the sparsity of time, but this is the framework, and it is very, very useful in processing insurance claims, processing GRNs, processing many of the documentation in the hospital. Internet of Things, and everybody talks about Internet of Things, but I do not know how many of them they are really using in the hospital. But these are all some of the IoT devices which are used in the hospital. We are using it here. This is an IV drip monitor. This is a temperature probe. Then this is a water meter. This is again a temperature for humidity, for ambience, and also for equipments. And these are all BLE enabled IoT devices for tracking. This is a small device to track the medical equipment like ventilators, monitors, infusion pump. And these are all BLE tags put on the patients, put on the employees. These are all some of the BLE devices put on the walls to measure the temperature. And this is the device that is put in the refrigerator in a blood bank or maybe even a watt station to measure the temperature where you have kept vaccines and all that. And these are all the gateways. Of course, there are a lot of other technologies which have come in like LoRa, Zigbee, 4G, 5G, all these technologies have come. So you have a variety of gateways, but it is not required for you to know all this, but definitely you must know that these also go along with these IoT devices. And this is a very typical IoT enabled drip monitor, very, very useful, especially for COVID patients. When there are about, say, 100 COVID patients in the hospital, we keep giving drips. When we give drips, we want to know whether the IV fluid is there or not. Every time the poor nurse runs from the watt station to the patient and sees whether it has got empty, or the patient has to run to the watt station to inform that the drip fluid is getting empty. So here in this case, we are able to get the data directly onto the iPad, and the patient is there, and it is reliable drop sensing, and it is closely monitoring the IV fluid. We are able to remotely monitor about, say, 40 or 50 patients in a ward. It reduces the nurse's workload, improves patient safety and audit reporting. Actually, this is this device has been developed by one startup company in Cochin, and it has got the award from Kao, and Zoho Corporation has also developed a device like this. This is typically what was happening before COVID. We were measuring all the temperature, humidity in all the equipments like refrigerators and also the ICUs and OTs. This was manually recorded. I am sure many of the hospitals still do it. The nurses are given this duty which does not add value to their work, and then the supervisors come and visit them and sign it. But now what we did was we used this low-code platform and the IoT devices, and then put those IoT devices and connected it to this low-code platform, and we were able to get real-time temperature and humidity of all the locations. Maybe we had about 50 locations like intensive care units, surgical OT stations, OTs, and then laboratories, and even some watt stations. And we were also able to know minimum and maximum temperature. This dashboard, analytical dashboard, instantaneously calculates the minimum and maximum temperature, average temperature, relative humidity, average humidity, which is very important in the operation theaters. Similarly, in the watt stations, you are able to measure all the temperatures in all the refrigerators, even in blood banks, if you want to see. In fact, one of my managers asked me from the lab, can you do it for my blood bank refrigerator? Can you do it for my other refrigerators in the department? Because we want to monitor it from the house, whether the temperatures are maintained. So this is again a GPS-enabled COVID ambulance where you can track. We have about 5 or 6 ambulances. All these ambulances are fitted with GPS. We know where they are going, how they are collecting the patients, when they are collecting the patients, coming back. And we have integrated all those ambulances into this dashboards and through the low-code platform. So we are able to know how many trips were made by that ambulance, how many were emergency trips, how many were routine trips, how many were trips for the service stations, how many were paid trips, outpatient trips, inpatient trips, how many kilometers, well, how many for emergency, how many for routine, what is even the total amount that is collected by the ambulance. In fact, I was very happy when an ambulance technician came and told me, paramedic came and told me, sir, you have made my job easier, because whenever we used to charge for the ambulance, the patient attendants used to feel bad that we are charging more. But once I had this data, once I showed them the kilometers through the OT device, the GPS device, they were very happy, and I am very happy and I am very thankful. I think that was the happiest day when I had it, when he came and told me personally. This is the IoT-enabled asset monitoring system. This is again very, very interesting. I am sure people like Rajamanikam will appreciate it. Suppose if they have about 200 ventilators in the state, if they have about say 500 cardiac monitors and about say 500 infusion pumps and syringe pumps, we can put an IoT device on this, and this IoT device will communicate with my platform and will tell you whether it is there and whether it is working or whether it is in working condition, how much it has used, and you can know the utilization. This kind of report is generated. What is the cardiac sum? What is the type of device? What is the model? What is the equipment code? What is the defined device name? What is the MAC ID status, whether it is working or not? What is the patient ID and what is the bed number ID location? How many hours it has been used? The advantage of this kind of an IoT-enabled equipment monitoring system is that we are able to know the utilization of that equipment for replacement, and we also know that it is available, and we integrate it to the billing system so that tomorrow in course of time, I'm sure the insurance companies will ask, if you charge about 50,000 rupees for equipment charges, they will ask you which equipment you used, when you used, how you used. We can give direct access to this platform, and they will be able to directly know the real-time use of these equipments, and there will be complete transparency to the patient and to the insurance companies. I am looking for that day. And this is the real-time location tracking. This is a very typical application we did in one of the hospitals in Coimbatore, Koi Medical Center. You find here the BLE tag. They had about 200 infusion pumps and syringe pumps. And we just put this tag, and we were able to track these infusion pumps and monitors and all that, where they are going, when they are coming back, whether it is in the place where they are designated to be, and how long it has been used. Similarly, we can also track the patients, we can track the employees, especially during the COVID times. We want to ensure the location of the patient, we want to ensure the location of the employee and the social distancing. And this has been found very, very useful. And this is a typical real-time location tracking system, equipment tracking dashboard, where you see here what is the time of entry, what is the time of exit, what is the duration, first floor, second floor. So we are able, just imagine if you are able to track all the 100 cardiac monitors, or maybe about say 20 ventilators which are used in different beds, we are able to track. And this is for tracking the patients. We have 40 master health checkup patients. These master health checkup patients, when they come, they go to dozen places. They go to almost 12 places, like maybe they go to ECG room, consultation room, ultrasound room, gynecologist. They go to all different places. We are able to know when did they enter, when did they exit, how long they stayed in a particular place. We are able to know, and we are able to optimize the resources. We are able to minimize their waiting time. We are able to optimize even the technician's time. And this is a great tool in the hands of the hospital administrator, but this is extensively used in Western countries. They're extensively used in places like UAE, but it is not being nicely used here. And I think the awareness is very less. And of course, artificial intelligence, it's a 1 hour topic. I don't want to talk much about it, but it is, we know what artificial intelligence is, but AI is all around us. And just an example is that in Coimbatore, in Koi Medical Center, Dr. Matthew Cherian was sharing a platform with me in the FICCI Chennai chapter. He was telling me that they did about 200 CT images per day, and it went through AI radiology software. and they took hardly about 4 minutes or 5 minutes for each CT scan, which otherwise it would have taken him 20 minutes. He also mentioned that it is not going to replace radiologists, but it is definitely a great tool in the hands of the radiologists, so that they can process more and more CT scans and their time can be used efficiently. So there are last 2 slides. What are the drivers of hyperautomation? The COVID-19, the urgent need for agile, flexible, and scalable solutions needed to add about 50 beds in HIS. We were able to add when the COVID situation, when we had to add 50 beds overnight, we could add. Otherwise, you would have gone to the HIS vendor and it took a long time. And emergence of technologies like artificial intelligence, machine learning, IoT, RPA, RTLS, low-code applications, and lack of skilled software professionals. We have a lot of software professionals, but the skill levels are still not good. So with this lack of skilled software professionals, we ourselves can become citizen programmers, and we can do our own programming. The process owners themselves can do almost about 50 to 60% of the IT applications we can do. And many people say, once you say hyper-automation or automation, they say it is extremely expensive. It is not expensive. In those days, building management systems from maybe Honeywell or Siemens were about costing crores. But today, the cost of IT is coming down, like mobile. The cost of hardware is coming down. Maybe there are switches which do multiple things. They also do Wi-Fi. They also do BLE. And they also have softwares which can come on SaaS basis, subscription basis. So you don't have to pay upfront. So the way you pay has also reduced, has also changed. And the changing customer perceptions and expectations. Now today, no patient wants to stay more than 5 minutes, especially in a COVID situation. So the customer expectations have changed, the perceptions have changed. And so I think that also is driving hyper-automation. And I must congratulate the Kerala government and the people for the extraordinary work they did in that smart cities and oxygen war room. And I think Kerala became the role model. I think people like Tamil Nadu and Karnataka followed them. In fact, there was a video which got circulated, and I would have forwarded it to about at least 100 people for them to know. If state governments can do, tell me why hospitals cannot do this. And I'm sure people like Rajamanikam will be able to drive this very well in the hospitals, both in the public sector and in the private sector. And last slide, what are the challenges in implementation? Healthcare is a slow adopter of technology, and support, we have seen that if it was in if it was in a mall, if it was in a factory, if it was in a banking, the adoption of technology is very easy. But somehow in healthcare, it has been very difficult. Support and encouragement from the top leadership. But if you look at Dr. Sahadullah, I think everything is automated. Everything he talks about only IT. He and his son and everybody talks about. But not everyone is like that. But I have seen many people still are little hesitant in supporting this hyper-automation and technologies in the hospital. The change management is again a problem. The legacy systems are there. People don't want to change. And heart of heart, they have a problem of job security. But people must understand it will not replace hyper-automation, or AI will not replace jobs, but it will only transform jobs. I think that is what they should understand. We should educate them. We should reskill them, upskill them, make them unlearn and learn. And lack of course, there is a lack of transparency when people talk about EMR. How many hospitals want to really implement EMR? How many doctors want to really use EMR is a question, but it is a little debatable. But I am sure government in another 2-3 years will make it mandatory for hospitals to have EMR when they talk about interoperability, NDHM and all that. And inadequate support from the support and incentives from the government was also one of the challenges. But if you see Singapore government, I want all the governments, state governments and central governments to emulate this. Singapore government is giving 80% subsidy to all organizations, be it a hotel or a hospital or a factory. If they implement hyper-automation, they will give 80% subsidy because that is for the national interest. They said, if all these organizations do, the national productivity will go up. So the last but not least, the regulatory authorities still insist on manual documentation, insurance payment document. We have to upload all the patient documents when they have to send by courier. Then if NABH people come, they still want the temperature monitoring sheets or safety monitoring sheets or checklist. I think that should go. So thank you very much. I think I tried to do what best I could do with a given limited time. And I again want to thank Vicky for giving me this opportunity. And I'm looking forward to some questions to answer. Thank you so much. Thank you so much.
Thank you very much, Mr. Padmanabhan, Anantha Padmanabhan, for having spoken to us on a topic so lengthy at a very short time. I'm sure that, this would be a one-day program otherwise. But, like our keynote speaker had said, Mr. Rajamanikam had addressed us. He was actually advising us on the need for hyper automation during COVID-19. And I think that has been very successfully said by you. But it might take some time in a country like ours or in a state like ours. So, but let's hope for the best, because you've put in so much of material to us, like patient tracking, ambulance tracking, AI, IoT, real-time location tracking systems. And I believe that most of the systems that you just said are more of assisting the doctor's assistants to monitor the patient quite well. Thank you very much once again. So that brings us to the end of today's session. And can we just have maybe, because we have overshot the time so much, there have been a few questions, but if the speakers do not mind, can I put forward one or two questions to you?
Yes, please.
Yeah. So I'm taking the liberty to post one question which has come up. That's basically to Mr. Gautam. How long will the vaccine protection last?
It's a good question. I think current thinking is probably at least maybe about a year, but the immune system is complicated, and question is, you can have antibodies declining, but still some other level of protection, T cells and other types of B cells that basically, so it's a two-step process in which you, after an immunization, you have an increase and then a decline in antibody levels. And then you have a second increase here. So that's an interesting feature of the immune system. So we don't really have the answer to that.
All right.
It's a two-step process. It's a two-step answer that nobody knows.
Yes.
Thank you. Thank you. Then the next question is could be to Dr. Rajalakshmi or to Dr. Aravind. Both of you can answer that because this is more towards are the vaccines safe? That is one question. And are the vaccines safe to be taken along with drugs?
Yeah, Dr. Rajalakshmi, please.
Yeah, vaccine safety is quite proven. The concern about thrombosis and rare events of neurological side effects, when you compare with the general population, we don't see a raise as far as for now. We have seen thrombosis post-vaccination, but COVID per se can cause thrombosis. The risk of thrombosis following COVID infection is much more than vaccine. So that's the message we have to get across. We have these reports, AFA reported, and there are several, mild to moderate to severe cases, and these are uploaded in the government portal. So what we find is a severe AFI that requires hospitalization or minimal. And the events of thrombosis as compared following COVID infection, as for the statistics, is less than COVID per se and in general population. That's the message I want.
Yeah, thank you, Dr. Rajalakshmi. And anything to add, Dr. Aravind or Dr. Anripan?
No, the question is the same. Like if you ask me, is driving in the highway safe? What answer do I have? I don't have any answer. Driving in the highway may be safe, may not be safe, may be safe for someone who is driving at a normal speed, may not be safe for someone who is even driving. Because it is true that in vaccines, one cannot expect that the vaccines would make life easier, it will have no side effects. It is not possible. At the same time, without vaccines, this disease will just let loose. So it's too difficult a question, philosophically speaking.
All right. Thank you. Thank you very much. If there is nothing much to add more, I think because we have overshot the time by more than half an hour right now, or rather 40 minutes. So thank you. Once again, I thank all of you for having been with us today evening. And I would now request Ms. Preeti Menon, Assistant Director FICCI, to propose the vote of thanks, please.
Thank you so much, Sri Bibu Punnaran, our co-chair of FICCI Healthcare Committee, FICCI Kerala State Council, and Director Medivision Scan and Diagnostics Center for taking ahead the session so beautifully ahead. And though Dr. Sahadullah is a part of us, for formality's sake, sir, a very big thanks from our end for heading this show. Then Dr. Rajamanikyam, Sri Rajamanikyam, Managing Director, KSIDC, who was there with us in spite of his very busy schedule to render the keynote address. On behalf of all, very big thanks to Sir. Special address was given by Dr. Zakaria, State President, IMA Medical Association, Kerala branch. Very big thanks to you also, sir, from our end. Then moving on to the business session, Professor Gautam Menon, Professor of Physics, Biology, Ashoka University, Dr. Rajalakshmi, Dr. Aravind, Head of Department, Infectious Disease, Medical College, Trivandrum. Sincere thanks from all of us here for rendering your valuable time for this event. Listened so many from the hospital sector in Kerala, and Dr. Anirban Hom Chowdhury, professor in charge of GB Pant Institute of Postgraduate, New Delhi, and Dr. Sri Ananda Padmanabhan, member advisory board, healthcare, Chennai. Sir, we extend our heartfelt thanks to you for rendering your valuable time and answering the questions put forward. And moreover, the participants for this program, so many of the experts from doctors, experts from the hospital sector were listening to this program. From FICCI, State Council, Health Committee, and State Council, we extend heartfelt, sincere thanks to each one of you. Thank you. Thank you so much. Thank you, each one of you.
Before we conclude,
Thank you so
like to especially thank our sponsors for the evening.
Yes.
Diagnostics.
Sorry. Yes.
Program. Thank you all once again. Thank you from the bottom of our heart from FICCI Kerala. Thank you very much.
Thank you, Ananda. Thank you.
Welcome.